Ladies and gentlemen, please take your seats. We're about to start.
COVID-19 has taught us a lesson. No country was sufficiently prepared for this pandemic. Worldwide, health systems came under a lot of pressure. Malaria, tuberculosis, and neglected tropical diseases have increased. Hunger and poverty have worsened for millions of people. We must prevent that in the future. Experts say that there is a considerable risk that there will be further pandemics within the next 5 to 10 years. So, we need to prevent diseases from spreading from animals to humans. In order to be able to recognise and control risks and pathogens early on, we need a global network of skilled health personnel and modern surveillance systems that pool data from different fields.
There is a lot of preparation that we take away from the current pandemic now. So we can expect health systems to function somewhat better. We can expect media communication, political communication to function somewhat better, but there is a lot of room for improvement in all of these fields.
In order to be able to respond quickly next time, we need funding, research and development, regional vaccine production, and fair access to medical countermeasures. In the future, no country must act on its own.
So the world needs to together. The stronger countries need to support the weaker countries for all of us to be prepared and ready to prevent and detect. So together, sitting together would make a big difference because, Zoom is different, but face to face, you can really understand what's going on.
Let's get started together. In pandemics, there's no time for neglect.
Ladies and gentlemen, welcome. There is no time for neglect. Indeed, and even though there are other issues and other news dominating the global discussion all over, it is very important not to forget that the next pandemic is actually a question of when and not really of if. Welcome, ladies and gentlemen, and also virtually to our audience to this event today, hosted by the Ministry of Development and also the Ministry of Health. Let me please especially welcome the Minister of Development, Minister Schulze. I would please ask you on stage to give us your welcoming speech today. Thank you.
Excellencies, guests, welcome to the BMSAT. Here are also members of the Parliament. Really welcome to this discussion here today. From your work as health experts, you all know there is no glory in prevention. In most cases, successful prevention is invisible. My colleague, the German Minister of Health, Karl Lauterbach, and I also know that full well. Yes, I believe there is little more that is more glorious than preventing deadly diseases. And that is what today is all about. How can we, as politicians, as scientists, as entrepreneurs, how can we, as the international community, prevent the spread of diseases, prevent the spread of pandemics? How can we be best prepared? As a result of climate change and globalization, diseases are spreading to world regions that were previously unaffected. Just recently, some cases of dengue fever were reported in Europe. As temperatures rise, tiger mosquitoes as vectors of the virus are feeling more and more at home, including in such places here in Berlin. That is just one of many examples. Infectious diseases don't stop at national borders. The COVID-19 pandemic showed how fast pathogens cross borders, even if drastic travel restrictions prevent people from moving about. Across the globe, people had come to realize that no one is safe until everybody is safe. But this is not only true for pandemic times. Health is literally a global public good that must be accessible to all people worldwide. If we take that seriously, and we do that at the BMZ, then we must also be very clear a lot has to change in how we promote global health in future. We need to address health in a comprehensive and interdisciplinary way that is based on solidarity, as proposed by the One Health approach. 3 elements are crucial. First, We finally need an international framework for communication and action which creates trust and set the rules. We need a global pandemic treaty. This will lay the ground for a swift exchange of data and a fair distribution of vaccines and medicines. And I hope that the agreement will be concluded as soon as next year, because pandemic prevention will either work globally or not at all. Second, we need better coordination both at the national level and the international level. At country level, the support provided by international actors need to be aligned with national health programs. For this work, countries need up-to-date and well-defined national health strategies. And therefore, Germany is working with its partner countries to improve these strategies and to identify areas where international support is needed. We also need better coordination at the international level. For this, a strong World Health Organization is the key, and I am glad that several WHO representatives are here with us today, including Margrein, Chikwe Ihekwe-Azu, and Jeremy Ferrer. And WHO is indeed already moving in the right direction by coordinating the negotiations on the Global Pandemic Treaty and the international health regulations. However, a strong WHO by itself is not enough. It also sees a need for the development banks to do their bit, and that is why I have joined with other shareholders to initiate a reform of the World Bank. It must step up investments in global public goods, including in the health sector. Other development banks should do the same. And at the same time, it is important to continue to support health initiatives, including Gavi, the Vaccine Alliance, and the Global Fund to fight AIDS, tuberculosis, and malaria. They have years of experience and are firmly rooted in the communities where prevention is needed most. However, these initiatives often have competing interests. To make their work more effective, they need to have more clearly defined mandates. We all know that prevention is better than cure. That is why the German government supported the creation of the Pandemic Fund. The first 19 projects are not now fully funded and demonstrate the Pandemic Fund's capacity for action. It is a huge success that this has happened so quickly. The fund is contributing to better health monitoring, better labs and diagnostic, and better trained specialists. However, it needs to have sufficient and reliable funding. Germany, as one of the fund's major donors, will keep up its support, and I would like to use this occasion to call on more donors to support the important work of the Pandemic Fund. We will also need better coordination when we are faced with massive outbreaks of infection in the future. We need a new mechanism that builds on the learnings from the international response to COVID-19. A window of opportunity for developing the first structures for such a medical countermeasures platform is now, before the next disease spreads across the globe. We must use it. The new platform should support the entire value chain, from the development of vaccines to getting the shot into the arms, from producing medicines and other medical products to distributing them, so that the access to health products is ensured worldwide when the planet is faced with an outbreak again. Health should not be a question of geography. And third and finally, we need increased cooperation with the private sector, for example, in the field of vaccine production. My ministry is working together with partner countries, the African Union, other multilateral organizations, and the private sector to increase regional production. The aim is to achieve a fair distribution of medical products worldwide and to help the African Union reach its goal, producing more than half of all the vaccines needed in Africa by 2040. Germany is providing more than 550 million euros under the framework of a European initiative to support efforts to develop production capacities in Africa, especially in Ghana, in Rwanda, in Senegal, and South Africa. And it is great that we can welcome guests from these countries here today and hear about their experience. Ladies and gentlemen, it takes time and efforts to reduce pandemic risk. We have to forge effective alliances, create the necessary structures, and invest in health before the next pandemic comes along. And there is glory in prevention. You all know that. And it is obvious that we need to act. The Chinese philosopher Confucius said that there are 3 ways to act wisely. One is based on experience, which is the biggest way. This is the way the international community went during the COVID-19 pandemic crisis, learning the hard way, encountering traumatic experience. The 2 other ways are much better. One is reflection, and the other is imitation, learning from best practice. Today, let us choose these other 2 ways and let us lose no time. It is time to act now. Thank you very much.
Thank you so much, Minister Schulze. Please stay here, don't leave. Welcome, Minister Lauterbach. We will talk about all the topics you just mentioned. We will have 3 panels on that. Before that, I would please ask you, Minister Schulze and Minister Lauterbach, to come up on the stage. There should be a picture, if possible. Yes, please. Nice. We learned. Thank you so much. Minister, the microphone, please. Minister Lauterbach, the floor is yours.
Thank you so much. Thank you so much for this warm welcome for everyone who is from Germany. You will quickly recognize that this is a better welcome for me than yesterday at the pharmacists meeting. And so I'm very pleased to be here, see so many friends, see so many people whom I admire, whom I work with. So it's a great pleasure. Svenja, thank you for the introduction, dear colleagues, ladies and gentlemen. First of all, I'm honored to welcome you for this joint high-level forum which we are having with the Federal Ministry of Economic Cooperation and Development and our Federal Ministry of Health. We work together, we work very closely in all of these issues. And first of all, dear Svenja, thank you for hosting the meeting, for your hospitality, and for the work that we do together for pandemic prevention, preparedness and response, and for the development of global health. And indeed, preparedness for pandemics and global health have to go together. One is not possible without the other, which is often underestimated. So our cooperation is exactly the type of cooperation which is internationally needed. Therefore, I could not think of a better place to host this common together, this meeting than we do here today. And we have very distinguished guests, whom I assume are already introduced. So let me immediately jump into what is ahead of us and what we have to learn. It was already mentioned, learning from experience also means to learn from the COVID pandemic. The pandemic officially is over, but for many people who suffer from the consequences of the pandemic is by no means over. And let me point out, first of all, that we still underestimate how many people are suffering from the consequences of long COVID. We don't have perfect numbers, but by now we have a much better understanding of long COVID, and we also have better numbers, as a matter of fact. And for example, I think that the estimate by the Institute of Health Metrics and Evaluation in the US assumes that there is 36 million Europeans, 1 in 30, who suffer from long COVID here in Europe. 1 in 30. That is very, very substantial. In Germany, we roughly think that we don't have good numbers, but we think that between 1 and 1.5 million people suffer from long COVID. And we also better underestimate, can estimate what long COVID means for those who are afflicted. There are studies that show that those who after 1 year have not cleared their long COVID symptoms, the likelihood of a spontaneous regression into normalcy is only 7%. So for those who haven't, let's say, been able to get over with long COVID, it's very likely after 1 year to become a chronic disease. And this is a particular problem. We had a meeting here a couple of weeks ago where we invited 70 international and national specialists for long COVID. It was a very good meeting, science-wise, but also policy-wise. We must honestly say we currently don't have a cure. We don't have a cure. We have a much better understanding of what is going on in long COVID, much better understanding. We see two large, let's say, affliction groups. One is more an immune deficit, and one is more or a dysregulation in the immune system, not a deficit, but a dysregulation in the immune system. And one is closer to, let's say, damage that is happening in the endothelium, in the smallest vessels. These are, let's say, most long COVID consequences you can group in one of these two groups. But for both, we don't have a cure. And both are very worrisome. For the first group, for example, ME/CFS is the most important expression, and this is very often happening to young women. And if you look at these young women who are often mothers and cannot take care of their children anymore, this is a tragedy for the whole family. These children wait for their mother to recover, but it is not forthcoming, it's not happening. So that is and we don't have a treatment to offer, and the quality of life of these young women is just horrible. So we must work on finding cures here, and I'll come back to this in a moment. But also the other group, where the endothelium is damaged, you see a major increase in heart attacks, in new diabetes, loss of renal function, strokes, transitory ischemic attacks, cognitive dysfunction, cognitive insufficiency. These are major consequences. And this latter group typically is older. More often men are basically the victims here. We must assume, from what we currently know, that this particular group is, let's say, long-lasting or standing endothelial dysfunction will in the long run also be at a much higher risk of developing further cardiovascular diseases, but also dementia. Even for Alzheimer's dementia, it is estimated that 50 to 70% of the early disease initiation is due to vascular changes in the brain. And these are exactly the changes, also exactly in the parts of the brain where we do see the consequences of long COVID. So therefore, we must assume, unfortunately, that we will have a big increase in the numbers of patients with vascular and non-vascular dementia, also Parkinson's disease. We also know that for those who suffer from long COVID, the risk of Parkinson's disease increase. It may even be the case that those who never develop long COVID, but have many episodes of COVID, never long COVID, that they also damage their vascular endothelium. This is highly likely. So therefore, we must work on cures, and this only shows how important a pandemic is for years to come, as a matter of fact. And long COVID will also be a problem for those who get the infection now. We can, with the immunization, with the vaccination, we can reduce the long COVID risk, roughly speaking, by 60%, possibly only 40%. But the best number is that we reduce it by 60%. This is the best number which is in the literature. Means that there is a 40% likelihood still standing for an infection after vaccination. These are millions of people. So therefore, the pandemic will be with us for many years. It is officially over, but post-COVID will be with us. We therefore need to be much better prepared for new pandemics, and I'm very honored to see Jeremy today here again. When I came into office and Germany had the G7 presidency, Jeremy and me, we were basically thinking, what are the biggest insufficiency? What is really missing for new pandemics to be better prepared? And we had a long list, as a matter of fact. We were meeting in an Italian restaurant here in Berlin, and we were basically, I think we agreed that the biggest, the biggest shortage is basically young people who are trained in pandemic control and surveillance and get such a training and do pandemic surveillance and do pandemic early control. Because this gives us the opportunity to intervene when there is an outbreak, and we still have the time to avoid that the outbreak becomes a pandemic. This is, let's say, the golden gap between an outbreak, which is likely to become a pandemic, and we avoid that it becomes a pandemic. And if that is going to happen worldwide, we need something like a workforce, an international workforce, highly trained young people who make that their task. We basically need something like a Fridays for Future generation for pandemic control. And this was what we were thinking about. Ultimately, the pandemic fund is the result of these discussions, as a matter of fact. The pandemic fund will not solve this problem entirely, but it is an important step into that direction. And therefore, I'm very honored here to credit, let's say, the ideas for it to Jeremy here, because if it hadn't been invented at that time, we would need to invent it now, because other than that particular investment, we don't have much which is new in terms of educating young people to be aware of how pandemics arise and to care for them. Let me try to, let's say, describe the scope of what is going to happen in the future. Once more, to, let's say, quote Jeremy. Jeremy said in an important article that we live in the era of pandemics. Is this an exaggeration, or is this likely to happen? I mean, will there be way more pandemics, or was this, let's say, was SARS-CoV a pandemic of which we do have one in 100 years, like the flu pandemic in the last century? What is the likelihood of more pandemics to come? Well, I agree with Jeremy and others that the risk of pandemics will grow exponentially, because we do know the risk factors for pandemics. We know, for example, that loss of biodiversity is a major risk factor for pandemics, because then you have an interrupted circle of, let's say, viruses that then jump from one species to another species, and by virtue of that jump, it is way more likely that you end up with a mutation, which is then also a mutation that works in humans. Is this speculation? No, it's not. We do know that 75% of all new infectious diseases are of zoonotic origin already now. We also know that with climate change, we will have interrupted habitats. And with interrupted habitats, wildlife comes closer to other human close animals and to humans themselves. And we do know that there is a potential, let's say, that there is a potential of 10,000 viruses which are currently harbored in animals, which could potentially also survive in humans and be the source of infectious diseases in humans. And if only, let's say, a couple of hundreds of these viruses jump into humans, and if only 10 or 15 ultimately have the potential for pandemics, then we have to avoid 15 pandemics in this golden space between an outbreak and a pandemic. This will be an incredible task. We also know that we will see an exponential growth, and there's very important studies about that my ministry will make available to everyone who is interested, because we have more migration. We have population growth, and we also have, let's say, in-country migration. These are all major risk factors for pandemics to happen, as a matter of fact. We also have more travel. We have more poverty. We have more poverty as a consequence of health expenditures. So therefore, the risk factors for pandemics are rising, and if we do not speed up more quickly with prevention, then the risk factors will work. Then we will simply see more pandemics, and we will enter what Jeremy so eloquently put, the era of pandemics. I think that WHO is doing an incredibly good job in preventing pandemics, and that is one of the reasons why we, as the German government, we really support WHO wherever we can. First of all, Germany generally believes that multilateral support is more efficient and also more effective than sporadic bilateral support. So therefore, we have a strong conviction that multilateral institutional support is the way to go if you want to have an efficacious, if you want an efficient and also an equitable response to future risks. But WHO in particular deserves this support. It was very instrumental, and indeed Mike is here, Mike Ryan is here, Chikwe is here, very instrumental in making the pandemic hub more than an idea, basically deriving a strategy how it actually can work, how the money is to be spent, what type of science is to be educated there, who should be eligible for these supports. The WHO does have its very important contingency fund. If there is no contingency fund and there is an outbreak, you cannot help. There's no way that you get into the golden gap between outbreak and pandemic if there is no contingency fund. And Germany is the single most important contributor to the WHO contingency fund. I think other countries should support more. We also very strongly support and believe in the WHO hub for pandemic and epidemic intelligence. Chikwe is here. I have recently visited the hub again, and I was really impressed in what short period of time such important work can be organized. It was very impressive. This is a very good example how, let's say, a very lean system is able to organize something like a marketplace for surveillance, for research results, for policy advice, but also for new methods such as artificial intelligence. So it's a hub. Indeed, I visit the hub for lack of time, roughly speaking, once a year, but I was definitely impressed how quick the advance was, to be astonished here. So thank you so much, Chikwe, for doing that wonderful work. Let me ultimately finish up. We do need a pandemic agreement. WHO is working towards such an agreement. Without such an agreement, we do not have clearly defined responsibilities. Clearly defined responsibilities are also mandatory if I want to get into the gap between outbreaks and pandemic. Because if it is not clear at the time when the outbreak is there, who is responsible for example, for informing the public, in what ways the quality of this information is warranted, and that those who do inform do not, let's say, acquire disadvantages from that those who inform, provide the information, are therefore most immediately and also first granted support, for example, in countermeasures. That is important. So therefore, we need a pathogen access benefit sharing system in the pandemic agreement. And I admire the leadership by Tedros and also by Mike, by Jeremy, by Jekyll, by others, in bringing about such an important pandemic agreement. It is in many ways surprising that now in year 3 after the pandemic, we still do not have such an agreement, now that we have seen how badly such an agreement would have been needed at the time when the pandemic occurred. Ultimately, I've already pointed out, we have to work together. It is a disappointment how little money is invested in long COVID research, for example. You would assume with so many people suffering from such an important disease, many young people sustaining basically a complete change in their life perspectives. You would expect that way more money is invested also from drug companies, but very little research in comparison to other diseases currently is invested in long COVID. We also must basically recognize, and it is an unfortunate recognition, but we must recognize that even now we don't have nasal vaccines in order to be better prepared to avoid infection. Because ultimately, if we are not able to cure and if we are not able to avoid long COVID by standard vaccination, nasal vaccination is the way which is most promising. And this type of research is vastly underfunded as we speak. And ultimately, we also, in my opinion, have an underfunding when it comes to surveillance. I've already mentioned the pandemic fund. This is an important measure on which we can count. It is important, it will work, but we would need more money for this type of surveillance improvement. And ultimately, let me point out what we can never forget at a meeting like this one, and this is where Svenja Schulze is a leader in the field. She has always pointed out there is no pandemic control without universal health coverage. And if there is no universal health coverage, we will not be in a position to, let's say, avoid the pandemics that we could have avoided if we were more capable to provide everyone with the countermeasures, with the treatment, with the proper, let's say, treatment in early stages of the disease and contain the outbreak, as a matter of fact. And finally, to finish with a number unknown, to bring too many numbers, I apologize, but if we were to provide universal health coverage for everyone who is currently lacking universal health coverage, the best estimates are that that would come at a cost of a yearly cost of, roughly speaking, $350 billion. Now everyone will think, well, $350 billion, that's enormous. Who is going to pay for that? But on the other hand, you also have to take into consideration that we spent more than $7,000 billion for subsidies for fossil energy, which is only contributing to more climate change. So wouldn't it be a much better world where we would cut a lot of our fossil energy subsidies and spend some of that money for universal health coverage? It would be definitely a more equitable world, it would be a more just world, and it would clearly also be a safer world. So thank you for your attention. Thank you, Svenja, for hosting this important meeting, and I'm looking forward to the results. I unfortunately cannot be part of the entire meeting. I would have liked to be so, but my team is here and they will report to me immediately after the meeting. I think this is a very important opportunity for us to come together and come up with new ideas, make policy out of these ideas. And indeed, it was a great pleasure and honor for me to be able to give a short presentation. I see so many people here in the field who have for decades worked on these issues. So let me assure you, I will definitely look very closely at the results of the meeting and try to learn as good as I can. Thank you for the attention.
Minister Lauterbach, thank you so much for your speech. I can't let you go though, because we have a panel where you will be participating. So please take a seat. It's the fourth one here. And Minister Schulze, if I may ask you on the stage. Hier der vierte Hocker, bitte. Direkt neben Minister Lauterbach. And let me please also ask Michael Ryan on stage. He's the Executive Director of the World Health Organization. Mr. Ryan, hello, for emergency programs. This way, please. Also, Jean Kaseya, Director General of Africa Centers for Disease Control and Prevention. Welcome. Please join me for the first panel. And Caroline Reynolds, please join us as well. She's co-founder of the Pandemic Action Network. Before we start, let me tell you, there is a QR code on the flip side of your badge. And after each panel, it would be great if you could just add a word of how you're feeling, how you think the panel is going. We will make out a cloud of words after that, and it's a kind of feedback and also just to sense the mood of where you are right now. So please, also virtually, there's a QR code on the screen. Just use that to give us a little feedback of how you're feeling with the panels. And now let's start to talk about what we're here today. We want to learn from what we experienced, especially in the years 2020, 2022. And if we recapitulate that time, it was a very turbulent time, a very tragic time as well. But we are entering now, as the minister said, a stage to think and to perhaps, probably, hopefully, design new structures and a new process that could help us deal with the next pandemics that will be coming. So, Mr. Kaseya, if I may start with you, in your first 100 days in office, what priorities have you identified for Africa CDC after the pandemic, and what would you suggest? How should we address them? How are you planning to address them?
Thank you very much. Let me first say, on behalf of my 1.4 billion Africans, I will extend the greetings, and we are so happy to be here. We thank the government of Germany for hosting this event and having opportunity to share with you some of our thoughts. Yeah, we have some lessons from the COVID. And these lessons are leading us not only for the 100 days, but also for what we are doing. Some of the lessons, the first one is we saw how Africa was so vulnerable on relying in this, what we call the international supply chain mechanism for the medical countermeasures. I think all ministers, they made it clearly that we lacked some of these medical countermeasures, and we are learning from this experience. The second one is about how to have a strong health system in place. When we are talking about the strong health system, the system that can deliver. I was discussing this morning with Amadou, who was telling me tools are not sufficient. We need to deliver, we need to implement. We have vaccine, but we need to vaccinate to save life. And to vaccinate, we need strong health systems. We need strong primary health care. The third one was about how to have sufficient human resources. We are talking about communities. We are talking also about the health workers. And the last one, as I can say it, how to bring a regional approach on the way to tackle all of these issues. What we did for the 101st days was first to position Africa CDC as the center for continental response of all of these diseases. And we managed to have a new structure based on the new vision that we have. We have a new strategic plan, a 5-year strategic plan that got a lot of input from all partners. And based on the new strategic plan, we have now the new structure of Africa CDC. This new structure is well fit to provide appropriate answer to all issues that we have in Africa. The second one, we started to take seriously the agenda of local manufacturing. Local manufacturing, not only of vaccines, but of medicines, of diagnostics, of all other devices, medical devices. Because for us, we are not just talking about vaccine, we are talking about all medical countermeasures that can help us next time to avoid what we faced during the COVID time. We also started to push too much the agenda of primary health care, because that one is what can make our health systems more resilient. And this primary health care with a strong component on community health workers. In many countries, we lack health workers, and we are relying mostly on community health workers. And then we had some clear guidance. And the last one we did for the 101st Day is to have what we call the Continental Digital Health Agenda. We know that we have a major issue on quality of data, and when we are collecting and we are analyzing data. And we need to do it at the continental level, because as the minister said, I want to quote that infectious disease don't stop at national border. This is what Minister Schultz said. And we know that we need to share information between countries. And that one is the digital agenda that we are promoting. This is what we did, and we are continuing to do that. And we believe that with this international cooperation that we have, this partnership that we are building, we can go far. Thank you.
Thank you, Mr. Kaseya. We will talk about all these points, about sharing data, also about local manufacturing, especially in Africa, where the German government is supporting. But first, I would like to know from Caroline Reynolds, how do you think can adequate financing be ensured to be prepared for the next pandemic? Is there a way that the Pandemic Action Network is thinking of?
Well, thank you, and thank you again to the German government for inviting me. And wow, coming off of this is such a timely and important forum. And I wish, frankly, we had had this energy and this purpose that we would have seen last week in New York at the high-level meeting for pandemic preparedness. This is the conversation that we need to be having, and the right framing, that there's no time for neglect. Unfortunately, we didn't see that level of, frankly, political resolve and call to action, but we can start it here. And in fact, I want to tell you both ministers, thank you so much for your remarks. And if you will see our call to action to world leaders, which we issued last week, and I will give you both a copy, so much echoes the things that both of you said today. And it is the time to recommit to this agenda. It's that we need to elevate political leadership on this agenda and sustain that political leadership, the kind that we're seeing here today at the highest levels. We need to strengthen governance and accountability. We need to strengthen equitable access to pandemic countermeasures, which both the minister and Dr. Kaseya have both spoken to. We need that one integrated, coordinated, and one health approach, and then financing, increased and sustained financing. Thank you, Minister Schulze, for stating very clearly, and both of you, the support, Germany's support, foundational support for the Pandemic Fund, which we really do. It's one of the bright spots that have come out of the past 3 years in terms of global action to decide to do something, to create something out of the global architecture. It's just the beginning. We have $2 billion committed so far. We need more. The gap is 10.5 billion per year, and that's an estimate. But we can get there, but it's all about political resolve and leadership. So thank you for that call for, we need the existing donors to step up, including my country, the United States, is the largest donor so far, 700 million. It's committed to do more. It can only do more if other governments like Germany, which has already stepped up, can do more, but also the rest of the G7, the G20, and in fact, every country around the world, because this is actually a global public good, is pandemic preparedness, to invest in pandemic preparedness and to address, as you say, that golden gap. There will be outbreaks, but they don't have to become pandemics. So what do we have to do on financing? We do need to close that gap. That's a major thing we can do, and that we urge leaders to do in this next year. Finish what you started. There was an agreement to create this. Let's get it to where it needs to be able to address all the issues that the ministers and Dr. Kaseya laid out and that are in our call to action. But it also has to happen at the regional level, as you say. We need more regional support and for financing, and then ultimately at the country level as well, right? Every country needs a plan, a National Health Security Action Plan that is costed, that is financed, that is sustained over time, that's adapted to the situation as it evolves. And that needs to be funded publicly, but we need to leverage more private financing. We need to leverage the multilateral development banks. As Minister Schultz has said, they can do much more. But let's at least start. If we can do nothing else in these next 12 months, let's get this pandemic fund fully financed. Thanks.
Thank you. Mr. Ryan, what does this mean for WHO as a central actor in global health?
Can you hear me? Yeah, okay, thank you. Thanks for the question. Just firstly, greetings from Dr. Tedros to both of you. And his apologies for not being here, but I think you can probably see how seriously he takes this meeting. If myself and Jeremy and Chikwe are here today, it's by way of recognizing the importance of the meeting, but it's also, I think, by way of expressing the gratitude of WHO on behalf of other peoples in the world for what the German people have invested in pandemic preparedness, even before COVID. Germany has been a very long-standing investor in epidemic alert and response, in research around epidemics and innovation, and the conceptualization of the Berlin hub occurred before the pandemic started. We were, so we were thinking about these large-scale data problems, issues of health intelligence, verification, predictive analytics, pandemic simulation. These were issues that were on the table before the pandemic, and that's a little bit, in some senses, my disappointment, because it's Groundhog Day. We're back post a big event, already losing ground. That's happened to me with West Africa and Ebola. 2003 SARS, Jeremy, the pandemic of 2009. We have constantly forgotten those lessons, and I think now maybe, and I think I have some hope that we can do something. We can do something about that.
This is why we're here.
Indeed, but we also have to remember we tend to. We tend, and I'll speak to the WHO role in this, we tend to always lurch towards the technological solution, and that's important. We need innovation and we need solutions. But as I speak today, there are dozens of diphtheria outbreaks in West and Central Africa. We have 31 countries reporting cholera this year. We've got active outbreaks in more than 10 countries, with thousands of people being affected. We have measles outbreaks occurring all around the world. We have the vaccines for those. We have the interventions, and we're simply not doing it. So the simple availability of a countermeasure is in no way a guarantee that it will be delivered to the people who need it. So we have to think, and that's coming back to what John said, what you said, Minister, primary healthcare is the basis of this. We talk a lot about surveillance and we talk a lot about countermeasures. For our communities, that doesn't mean much. Communities want to know, how are you going to protect me and my family from these diseases? And if you can't protect me and I get sick, how are you going to take care of me and save my life? They're the two things communities worry about. Good surveillance allows us to be aware there's a problem. Countermeasures allow us to intervene. But there's another factor that has driven the pandemic response, and that has been misinformation, disinformation, the infodemic we're dealing with, the collapse in public trust. Right now, I don't believe that we've ever been at such a low ebb of public trust in government, public trust in medicine, public trust in science. And it's something we're going to have to deal with. So as we address this problem, I think WHO, as a multilateral institution, we are, and I say this all the time, WHO is not a secretariat in Geneva. WHO is not a building in Geneva. WHO is the combined will of 194 sovereign countries who work together to better the health of their people. And in that context, the governments matter, the parliamentarians matter, communities matter. We are simply the expression of the will, the collective will of those countries, whether it be in the area of primary health care or pandemic prevention or cancer treatment. Our role is simply to give life to the will of the World Health Assembly, in the same way that government policymakers are supposed to give life to the will of the people. And I think that's why we should reset today and not say, and Carl always says it, and thank you both ministers for your support to WHO, because I know you support WHO because you feel you're part of it. You are the governing body. And in that sense, WHO becomes very important. We've made one mistake, and I'll make my final point on this in a sense. We've very much verticalized. There are many great initiatives over the last few years, but we have verticalized interventions of health into countries. And if you're sitting down at the Ministry of Health, I remember the Minister of Health in Nigeria many years ago saying that he had 70 different international health representations in Abuja. How do you expect me to manage? It's great. Verticalization works. You can go right to the point of the problem. But unless we get back to investing in systems at local level, community level, local level, national level, global level, unless we integrate and flatten what we do. Before the pandemic, 106 countries had national action plans for public health security that Caroline refers to. They had gone through joint external evaluation. They had done after-action reviews. They had carried out exercises and simulations to test their system. They had identified the weaknesses in their system. Can you hazard a guess how many of those plans got funding from the international community? Of the 106, 3. Therein lies the seeds of the pandemic impact. Countries knew what was wrong. They knew what was missing, but we simply did not have the governance and financial architecture to change the dial. And we didn't have the capacity to deliver the systems that were needed to make good on that, on the needs in those plans. So the pandemic fund, financing, national planning, all of this needs to come together. And for too long, and we have to also look at national accountability. It is the sovereign responsibility of the nation state to protect the health of its people. It is not the job of the international community per se. It is the sovereign, but it is the solidarity of the international community that can bring assistance to everyone. We have got to get away from a situation where we could see public health security as an external funding issue. Public health security is primarily a national security issue, a national health issue, but for so many countries, this requires a massive investment. And we need to bring that investment to bear over a long period of time and not have a total reliance on international funding. So we have lots to do. WHO has much to do with the treaty, much to do with the pandemic fund, much to do with working with colleagues like the Africa CDC, CSOs represented here today by Caroline. So we look forward to doing it.
So the pandemic accord is the first step in the right direction, you would say. And I mean, the main issue, as I understand, is how to show also people how important this is for their own lives. And their information, of course, plays a role, but also the dialogue between the countries. Mr. Lauterbach, you are in constant communication with G20 health ministers. Is that paying off? Are you also talking about these issues?
Yes, definitely. First of all, we made pandemic preparedness one of our 3 priorities at the G7 meeting, where Germany was leading the G7 group. And we have also worked within the G20 groups that, for example, long COVID and pandemic preparations become priorities. Now you can say, well, it makes no difference that this is a G20 priority. I do think it does make a difference. If you ask yourself what are funding priorities, what cannot be neglected because it is part of the priorities, then G20 is important and G7 is also important. And we, in my opinion, should not, let's say, only stress what has not been achieved, but also see where there is improvement. I agree that there is a long way to go when it comes to universal health coverage. That is quite clearly the case. But nevertheless, I'm also convinced that quick and immediate support of countries where an outbreak is happening and where a pandemic is to be avoided is possible and necessary. And I don't think that we can have an international fire brigade for this, but we have to have people in their countries that are knowledgeable about these issues and recognize the problem. And I think that if there is a real risk of a pandemic to happen, in at least in that international field, we will be much better prepared. The new enemy, in my opinion, is what Mike said, misinformation. Ultimately, the second pandemic of our time, the pandemic of misinformation. Because this makes it way more difficult to have people do what will ultimately help them. The misinformation will make it much more difficult to explain in a more innocent way what is scientifically proven, what is scientifically known. There will be resistance against whatever governments advise us to do, whatever the next pandemic will be. So in that sense, we are, let's say, worse prepared than before the last pandemic, because of flood of misinformation and, let's say, the pandemic of misinformation, fake news, will in a couple of years, because artificial intelligence is also supporting that so quickly, in a couple of years, everyone who gets health information by the government will first assume it is fake news and only hopefully consider it may not be fake news. Fake news assumption will be the new normal. So if I, for example, in a couple of years will be confronted with a new pandemic, the biggest task will be that we get through with our information in such a way that it is not in itself regarded as fake news, not to speak about the fake news that acknowledge that it is not fake news, but it is wrong. So we will basically have a double challenge here. Our own messages will be regarded as fake news, and if they are ultimately then regarded as true and not as original and not fake, then fake news will be used in order to counter. These will be new countermeasures. So while we pile up countermeasures in the traditional sense, new countermeasures are piled up by those that live politically and economically from that type of an attack of what we are saying, but in virtue of fake news. And I've just come back from, let's say, an impressive meeting which we had. We had basically a meeting with researchers at Harvard University, MIT, Mayo Clinic in Boston, basically on artificial intelligence, because we are involved in major digitalization laws. And it was incredible in these workshops to see how, let's say, on time, basically online fake news production by artificial intelligence will work in the future. It will be almost impossible to distinguish between the original and the fake. And that will be a task for us ahead.
Yeah. As a journalist, I must add that this is also one of the reasons why we need quality journalism, right? Let's not forget about that. Sorry, I just had to put in my point as a correspondent. Minister Schulze, briefly, we don't have that much time, but I'm really keen to know, you as a Minister for Development are a lot in the Global South, in Africa, Latin America, Asia. Are the concerns there similar to the ones we are talking about here? Misinformation, do they want to be prepared? What have they learned from their experience during the pandemic?
Yeah, this is the same. Jean said that before, that they be aware that they need a strong health system in place, because what we do not discuss, but it is the fact that with COVID-19 we see reversed progress on poverty-related illness and other infectious diseases like HIV, malaria, tuberculosis, and neglected tropical diseases. So there is a backslash on that. And bringing steps forward, we need to do more than we did before. And that is what is seen, but there is always a lack of money. You said that before, the plans are there, but there is no money to bring them really in place. And there is also a lack of trust in between, because there were failures during the COVID-19 pandemic that we here in the industrialized countries get the vaccines first for ourselves and not for the global south. That is really, really a failure, and we need to build trust again, that we will not do that again. And building that trust therefore, such discussions as we have that here today are really, really important. Having the trust that we get the solutions together, that we learn from the pandemic, that we know how to get forward, and that is what we need to do. Building, for example, capacities for vaccine production on the African continent. That is really, really important. The goal is really clear. The African Union said that they want to produce vaccines, and we need to help that they are able to do so, that they have the right knowledge in place to bring that forward. And building this trust again, I think that is really, really important to work together on the world. It is just one health. We need to talk about again that we have this approach and that we need to work together.
Thank you, Minister Schulze. Just a brief question on that, because we are, of course, in a time of big crisis worldwide. And also on a financial level, your ministry is noticing the impact of that. So you need money in order to make these projects. How are you dealing with that?
First of all, we need to lead by example. We do a lot in that. We invested over €1 billion last year in global health. That makes us one of the biggest donors. And don't applaud for that, because that is the problem, that we are the biggest donor with that. We need more money. And what we do is driving forward, advocating for more money, talking about that it is cheaper to invest in be prepared for the next pandemic. It is better to do that in that way. We need to learn from what we experienced over the last years. And what we do additionally is going forward, for example, with the World Bank, changing their way of giving money to save global public goods as the health system. We need also more private money. We need the World Bank to be able to get more private money in, to bring it to the countries who need it. And the banking system needs also to play a role in it, because we are not able to finance that only with the money from the states. We need also the private money. We need the companies to invest also in the global south. And that is what we drive forward. We do that together. We do that with the European Union, and we try to find allies for that. And you are the ones who we discussed today with, because we need these alliances, we need partnerships, we need to do that together.
This is also why we're here today. Thank you so much, ministers, and thank you to the panel. Before we go, I would like to take one question, just one question from the audience. I'm sorry, we're running out of time. Is there someone who has an urgent question for this panel now? Okay, you were the first one. Helena Hamilton, please.
Hi, I'm Helen Hamilton from WaterAid. So first of all, thank you to the whole panel. It was fascinating to hear your perspective. Many of you have spoken about prevention. Prevention. We've heard, there should be, rightly so, glory in prevention. Working at WaterAid, we know one of the most cost-effective ways to support improved health outcomes, as well as contribute to pandemic preparedness and prevention, is really focusing on clean water, sanitation and hygiene, particularly when we know around, a quarter of the world may not have access to COVID vaccines, and we know that that's concentrated most in the areas where WASH isn't present. So my question to the panel is, how can we make sure that work on prevention has a really strong cross-sectoral focus, particularly around the financing aspects, where we know no one disagrees. I can see everybody on the panel nodding, but how do we take the nods to genuine action to make sure that financing and political will are really driving that collaborative, multi-sectoral action, particularly in line with the One Health approach?
Are you addressing your question to someone in particular, or?
I will address it to maybe the ministers and to Mike Ryan. I think that'd be great.
I should take it. I think we need to show that by example. That is not only a theoretical idea. We need to show that in the way we are doing our projects. And therefore, we need to do more together. I know it is really good having a project from Germany with the German flag, and every member of parliament is happy to see the German flag on a project. But doing that together, bringing the knowledge together, I know it's easier to say, it's easy to say that here on a panel, it's easier to say than to work with it. But we need the experience from different partners on the regional level. We expect the partner countries in the global south to do that work, to bring all the donors together. And that doesn't work. We need to be partners and really deliver solutions. And we need to coordinate ourselves and then bring the solutions to our partners, and doing that together with this integrated approach. And that's, I know it's not easy, but we just need to do it. The knowledge is there.
Minister Lauterbach?
I think, yeah, I fully agree with what Minister Sven Schulze has said. But additionally, I think, and again, this is covered by her intervention, additionally, we also have to look at the reality that there is very, very, very little really high-quality science out there in these issues. For example, cost-effectiveness studies that show how wonderful the cost-effectiveness is, for example, in sanitation, in avoiding diseases, not only pandemics, but diseases which are difficult to take care of. So we are vastly under invested in prevention science, as a matter of fact, studies in order to then advocate evidence-based policies, not only internationally, but also in our countries. I can give you an example. Germany, for example, in total, if you look at all expenditures that we have, private and public for healthcare, we roughly speaking have expenditures of 485 billion euros per year. That is very substantial. But if I was to assume how much we spend in, let's say, very high quality science for prevention, studies for prevention or so, it is clearly less than 100 million. So in that sense, we 4,000 times expend on, let's say, care, treatment, and so forth, what we invest in, let's say, good science in order to find better ways to avoid these costs. And this is not only the case in Germany, it's the case everywhere. The high-quality science in prevention studies, in particular cross-sectional intervention studies, where I do look at, let's say, nutrition, where I do look at, let's say, vitamins, where I do look at sanitation, where I do look at climate change. So high-quality science in these fields is vastly underfunded.
Ms. Reynolds, you wanted to ask to add something, and Mr. Casey as well.
Yes, I think the way to approach this cross-sectoral prevention issue, we have to take it on programmatic way and financial way. Programmatic way, we are talking about the One Health. I think more likely the next pandemic will be a zoonotic one. I think Minister Karl talked about it, and worsened by the climate change. And we, in Africa, I'm talking about Africa because I'm Africa CDC, we developed a strong One Health approach strategic plan at continental level, supported by all countries. But on financial aspect, I think we are pushing more for the PPP, the private-public partnership. We need to bring the private sector on board, and that is something critical in Africa. The second one is we need to ensure that some global mechanisms are well funded. We are talking about pandemic fund, which support pandemic fund. But we said we need a regional approach for pandemic fund. I think that one, we are so clear on that. We don't want the country proposal, we need a regional proposal. I think we'll discuss that during the next meeting in Morocco. And we are also talking about how to provide more funding to Gavi, to a global fund, to continue to support and to bring more resources based on our needs and priorities. The last one I will advocate, Germany is doing a lot. I think Germany will also sign a MOU Africa CDC next time.
Very quickly, because I know we're out of time, but I just want to answer this from a different angle. So we can't we have to do prevention, we have to do preparedness, and we have to be ready to respond to whatever comes next. And we can't let those things cancel out each other. We have to invest all of them. There's enough money to invest in all of them. It's a matter of political will. And it's our mindset, right? It's our mindset. It's great today that we brought together the domestic, health ministry, the economic development ministry. Next time, let's have the defense ministry. Let's have the Ministry of Finance. Let's have the chancellor here. Let's make this like the Munich Security Forum, right? Leaders around the world at that level committed to this, because with a defense mindset, right, we're always on. We're always prepared.
Go ahead.
We invest in the next generation of tools.
The minister wants to answer to that question directly.
We will do that.
Excellent.
We will do that next year.
Let's make it the next pandemics conference.
It is called Hamburg Sustainability Conference, and we will bring together all the leaders from the private sector, from science, from the political science, from companies, to discuss how we could accelerate our work to bring the SDGs forward. And like the Munich Security Conference, but just for the SDGs. And we will invite everybody who likes to join that.
The German government ahead of your question already, of your comment. We have one more question from the virtual audience. Let's not forget about them. They're asking, do you think the UN high-level meeting on pandemic preparedness, prevention and response, PPR, last week in New York was a success? And if yes, why? And I think that question clearly goes to Mr. Ryan.
Just one sentence on water.
I'm sorry, but it's quite clear.
One sentence on water.
Okay, sure.
I can't remember who said it, but I think it's relevant. If the cure to all illnesses on this planet was a single glass of clean water for every human being, we couldn't do the job. And I think that says something in the 21st century. So respect to WaterAid, a fantastic organization, and what you do in providing basic water security for people in an area where water is going to become a commodity that we'll fight wars over in the next 100 years. I think something needs to be applauded for the work that WaterAid do, so thank you. Yes, Caroline has her own view of the world. It's a good job we're separated by a panel.
That was the idea.
There's an old saying, I think, that what doesn't kill you makes you stronger. And and you know this in politics and in diplomacy. The most important thing is we maintain forward momentum.
That's right.
The most important thing is we can go to the next step. And when you bring together hundreds of nations in New York with everything else that's happening, this may be relevant in Germany particularly. There's a saying, I don't know if it's originally German, it says, if you like sausages, please don't go to where they make the sausages. Same with politics. So I think we have to accept that the world leaders came together. They've agreed to recognize the impact of the pandemic. They agreed to say we can never let this happen again. They've identified a clear number of areas in which we need to make progress. Now the ball is back with us. We've got the negotiations on the treaty. We've got the revision of the IHR. We've got the pandemic fund. We've got various initiatives through the G7. And again, I'd just like to recognize Carol's personal leadership. We have a Global Health Emergency Corps project we're working on. Carol has driven that personally through a number of years now. We've got huge work going on at that. We've got the medical countermeasures platform, the interim platform to build together. And that's been endorsed by the leaders of the world. So there's enough work to do. I do think that next May, the countries of the world will come together, I hope, and there will be a solemn agreement between states that says, in vernacular terms, to the people of the world, never again. And that agreement will contain the elements that will make that true, in terms of surveillance, in terms of community protection, in terms of scalable clinical care, because our health systems were strong in the north, but they failed in the pandemic. Strong health system is not enough in an emergency. You need a resilient, flexible, scalable health system available to all. And that is an absolute requirement to adapt. We need access to countermeasures. We need strong collaborative surveillance. And most of all, we need coordination. everyone knows that in a crisis, chaos is your enemy. Emergencies are chaotic, but the more you take the chaos out of the process, the more you can help people. It's the same in a busy emergency room. It's the same at the scene of an accident. It is those who are calm and prepared, who understand what they can do, are prepared for that, and then are able to do the extra they need to do because the situation demands it, which you will never be able to perform at any level in an emergency situation unless you are conditioned to do that through practice and preparation. It doesn't matter if you're a sports person, it doesn't matter if you work in mountain rescue, it doesn't matter if you work in global epidemics. It is the basic principle of emergency preparedness, and we need to learn those lessons fast.
And to give an answer to the question virtually, would you say that the political declaration signed last week in New York on the high-level meeting, that was the first step in that direction?
It's the first time in history in the United Nations that all member states came together and said anything about this, right? So
It's a start.
I'll take it. It's a start, right? Yeah.
But we have to turn that document into action. And how does that happen? That happens through advocacy and through all of you also being part of that effort. That's why we created the Pandemic Action Network and bringing organizations together around the world to keep this on the political agenda.
Great. Thank you so much for this round and the optimism at the end with the document signed last week and the steps that we're looking forward to take together. May I ask you to stay on stage? We'll have a quick family picture, also the ones who will be participating in the next panels. Please join me on stage. We will have this family picture here. And for the other ones, there's lunch. We will meet here at 2 p.m. So you're welcome to join the lunch. It's going to be on the left side, right? On the left side is the lunch. Wir machen das Foto hier. Genau. We will be standing here, yes. thank you so much for coming back. I hope you're feeling well. Lunch was very nice, wasn't it? Could someone please close the door over there and maybe on the left side? And then let's get started. We can see some of the words. I don't know if we can put them on screen again, that you have been dropping through your QR code. Hygiene neglect is one of them. One Health, of course, all things we have been already talking about. And we will also touch on these topics in the next panels. But before we start with that, I would like to ask the Chief Scientist of the World Health Organization, Mr. Jeremy Farrar, to join me on stage, please. We are very keen to hear your words. Thank you so much.
Thank you. Thanks. Thanks for it. This is my prop because otherwise I get too nervous. It's a great pleasure to be here on many counts, and thank you for the invitation. And as Mike said earlier, to have both Chikwe, Mike, and all three of us, not both of us, here at the same time, I think sends an important signal of how important WHO feels this meeting is, and the continued dialogue it is. And also pay tribute, because it doesn't often happen, no comment on the federal government of Germany, but in many other governments that I know, where two ministries come together and share a common interest. And I think unless we can break down those, both within governments and unless we can ultimately break down silos in what we do across many aspects, I don't think we're going to be able to address the title of today's discussion. So firstly, I'd just like to make some comments on where I think we are, the world that we currently live in. And perhaps the first thing to say is pick up on a comment Mr. Lutterbach made earlier. COVID is not over, and it's not going to be over. We're not going to finish COVID. COVID is with us now forever, whether it's be as an endemic infection with variants being developed, or indeed it's the 1 in 30 or 40 people that have long COVID. If you think that around the world, and I'm one of the very few people now, maybe one of the 1 or 2, 3% that's never been infected, which is remarkable. I probably will be after today. If you have 6 or 7 billion people infected and you increase the risk of diabetes by 0.5%, you've got a big long-term public health problem. So I think we mustn't think that the pandemic is over, even though the public health emergency may be. I'm going to say 3 things. One is a comment on the times that we live in, some of which was picked up in the panel this morning. Second thing, and maybe perhaps the most important thing I'll say, is it is what you have before a crisis hits that matters. And then whether you sustain that. And as the chief scientist, I'm going to make an argument that unless you invest in basic science, you won't have what you need when a crisis hits. And then thirdly, to pick up a bit of optimism, and again, Mike mentioned this at the start, it is important that the political declarations do matter. Try and achieve something in global health without political support. You can't. Does political support translate into action? As Carolyn said, no, not necessarily, and that's why pushing the political class is so important. But try and do something without that political support, and you'll get very little way. So the context of the world we live in, whatever age I am, I'm not sharing that personal information, but I was born in the 1960s. I've never known another time in my professional or personal life which has felt so uncertain, when the things that we sort of certainly through my life, came to believe in and trust have been more challenged and more questioned. Not just science, trust in institutions, trust in government, trust in people within institutions, as a strategic political ideological move, either to create chaos or to create a political momentum behind a particular view, and that's been the rise of populism. But at the same time, we still have the pandemic, as I mentioned. We still have many ongoing epidemics, and one word of advice to the global north is to not present everything as a threat to yourselves and only be interested when something is a threat to yourself. Regional epidemics can be devastating. Go to Dakar at the moment, go to Bangladesh at the moment with a huge dengue outbreak, cholera outbreaks, et cetera, et cetera. So I think we need to shift how we think from this is something that frightens us in Washington, London, Berlin, Paris, to something that's critically important all of the time. So the world we live in is complex, inflation, intergenerational issues, gender issues, mistrust, questions of the survivability of our institutions. And at the same time, we have a political, it's good our two ministers have left maybe, although I know both of them and I know they would share this view. We have a political system at the moment which drives very short-term thinking. And a very short-term approach that what happens this afternoon matters, and maybe next week, maybe next month, but probably not next year, because I may not be here as a minister or as a government. And yet our long-term challenges are where we're going to have to invest in the long term now in order to address those challenges that are coming, whether that is the existential crisis of climate change, demographic shifts and aging, not just aging population, but shifting populations' age structure, coming of multimorbidity. And that will mean health systems that are going to have to be evolved into that new world rather than the world we've come from. But also an era that we've come to appreciate during COVID, which is the tired phrase now a little bit, that no infectious disease stops at any border, but nor does non-communicable diseases now. There is a convergence happening in global health so that something that happens in Wuhan, China in December 2019 affects Frankfurt, Berlin, London and Washington pretty soon. But in the reverse, in a way, diabetes, cardiovascular disease, obesity and the diseases that go with it are also going to affect. That will change the nature of how we deliver healthcare and the opportunities for how we are not making, in my view, in almost any health system in the world, those changes at the moment. In this section on the world that we live in, I just wanted to pick up in the sense of one disease, which I still think is probably the biggest risk to the world in terms of an existential crisis, and that's influenza. Influenza of 1918 is something that is stared on all of those of us who read medical history. But just imagine, as we live through an animal pandemic of H5N1, and I spent 18 years living in Vietnam in the midst of the H5N1 crisis in 2004 or 5, when I first started to work with Christian Drosten here. This is a disease which, in my experience treating patients in Vietnam at that time, kills 50 to 60% of individuals. Now, it may not do that when it's highly transmissible, but we are watching, we are surveying, and we're reporting on a global pandemic of animal H5N1 at the moment. And we do not know really what it would take for that to come across into humans, maybe not with that lethality, but with others. So the comment there is that influenza still haunts us. We have the surveillance system in place. We have a global influenza network, which is far from perfect, but has been in place for 70 years and is still functioning, including in most parts of the world, and including an arrangement with industry so that they are part of that network. So it is something to build on rather than to discard, and it could be lessons for how we work on the future in other infectious diseases. But take influenza and ask yourself, we can report it, and I have been quoted, and Chikwe is not here, so I'll say it bravely, surveillance is stamp collecting unless you do something with it. And ask yourself, for the one disease which probably frightens most of us, yes, we have genomic surveillance now, but do we have rapid diagnostic tests, and are they available globally to be able to be used tomorrow or next week or next month? The answer is no. Therapeutics. Don't prepare for the last pandemic, where a vaccine was remarkable in how it was developed. We may not have a vaccine for the next one. We haven't got a vaccine for HIV. We may have a vaccine this decade for TB and malaria, but a magic bullet won't necessarily work, and therapeutics and clinical care will be critical. Ask yourself for influenza, have we got great drugs for influenza? No. We don't even know, some people would argue, whether they work or not. I happen to believe they do, but we really only have one. We don't know whether to give it orally or intravenously. We don't know what dose to give. We don't know whether we should give a bigger dose at the start or later. We're not combining it with anything. So drug resistance, if 5 billion people are infected, would develop immediately. And vaccines that are not perfect either. And we don't have vaccines in phase 1 and phase 2 early clinical trials to cover all of the novel influenza viruses that could come across into humans, which to me represents the biggest threat to humanity. So for the infectious disease, don't forget disease X, don't forget the coronaviruses, don't forget the hemorrhagic fever viruses and all the others. But influenza remains a huge threat, and our countermeasures, even for that one, remain poor. So that's the world we live in, a pretty pessimistic one. The optimistic next section is about what you have before really matters. And what I would love to see, as well as the finance minister here, is the Ministry of Science and Technology here as well, because COVID vaccines were not developed in a year. That is legend and myth, and I hope gets rewritten in history. COVID vaccines started in 1988, 1989, 1990, with basic science, actually in the US and actually here in Germany, looking at mRNA and other types of mRNA. It was that 30-year investment in people, in institutions, in discovery science, which led to the COVID vaccines being able to be developed in the period of 2020. If we don't continue to invest in that basic science, and if we don't continue to invest in the health systems that will deliver those vaccines, then we won't have the interventions, the medical countermeasures when we can't. You cannot turn things on in a crisis. That goes to basic science, it goes to manufacturing, it goes to regulation, it goes to public health institutions, it goes to trust in government, it goes to the health systems that deliver it and the health workforce. So the better approach, whilst, yes, taking a perspective on pandemics, is to focus on things that are needed all of the time. And then those have sufficient resilience and surge capacity that they can shift and pivot when necessary in a crisis. So my plea here would not be to think, and I come from a background in emerging infectious diseases, don't totally focus on pandemics and epidemics, focus on what's important all of the time. Because if you don't, whichever government you're in, no matter how rich you are, I promise you within a few short years, that stuff will stop. Because new governments will come in and say, well, the pandemic wasn't as bad as we thought it was it? Only a certain percentage died, didn't they? And I've heard it said, not from me, but from others, they were of a certain age anyway, and they were going to die pretty soon. The pandemic will fade from memory. And if governments don't find utility and value in what they're investing in every Monday, every Tuesday, every September and October, then they won't continue to invest in it. So invest in the basic science, invest in people, invest in institutions, and make sure we build trust in institutions, and make that part of our culture rather than something done in ivory towers by people in white coats that can't put two words together. The last point is to leave you with four thoughts. We live in an era of really challenging times, but throughout history, you don't come through those times randomly. You come through them because people do things that make a difference. And there was the gentle debate earlier, or even argument, about whether all this political rubbish was of any value. You have to believe it is, because in our fractured world, to have 190-odd countries coming together and saying, yeah, we will put this forward, as I said earlier, if you don't have that, you'll get nowhere. So we should celebrate that. We should celebrate the fact that actually, although I know there's the anti-science agenda, I know there's people who have had death threats, as I've had over the last 2 or 3 years, but actually the trust in society of some things has increased, including actually in the WHO before I started. Things have dropped down since the last 3 months. Trust in science and scientists and the medical, broadly defined medical and public health communities actually is higher. Look at the Edelman Index of January 2023. There is something to be built on there, but you don't build trust in a crisis. You build trust because your communities know you're not just there when a crisis threatens in Washington, because they're there all the time. When I was in North Kivu with Mike and Tedros a few years ago during the Ebola crisis, many people in the community said, why are you interested in Ebola? Yes, it's a really important thing, but so last month was my malaria, or my child with mental health issues, or my maternal child health, or everything else. So let's do things which are sustainable. The mRNA transfer hub, and Amadou is here, and I'm sure he'll talk about it, we have to shift the centre of gravity. This will be uncomfortable for many funders, particularly government funders, because it means funding somewhere else, outside your country. And for countries in the global south, it means increasing the domestic funding for science research and the health systems. We cannot have one without the other. This cannot continue in a unilateral way. There has to be more domestic funding, because ultimately that will make the difference, supplemented and supported and leveraged by other funding that comes internationally. But governments and other funders, and I was 10 years head of a half-sized philanthropy, you're going to have to get uncomfortable by funding outside your national borders, and you're going to have to make that case to your public, that it's in your interest to do so, as well as the world's interest. And the mRNA hub, the technology transfer of mRNA is a critical example of that. But on that, I'll go back to the point I made earlier about sustainability. If those mRNA hubs, Amadou, are only focused on mRNA and COVID, they will not be there in 10 years' time. We have to work out how they will be used for endemic infections and non-communicable diseases so that they provide value and utility to their communities. There is an industrial and business case, and governments are willing to invest it. So whatever we do for the pandemics, let us make it of value and utility all the time. And the last comment to finish on a sense of optimism, I do believe with these things in place, the UN General Assembly, the Pandemic Accord, and I'm optimistic by May of next year there will be a solution on the pandemic treaty or accord. It's in nobody's interest that that does not happen. There will be elections in many parts of the world, this side and the other side of the Atlantic in the next 2 years. If you don't get a resolution by May of next year, forget it. So it's in nobody's interest that we don't get a resolution, and usually human behavior has a rational side to it, not always. Where your incentives flow, you'll probably make a better decision over time. And the incentives are to get an accord for everybody. So I do believe there'll be an accord, but I think my one single message is let's build those in sustainable ways, make sure science is part of our societies, make sure we invest in the long term, so that when something happens, a health system, a horizontal health system, the science will be available and it will be equitably distributed because the center of gravity for its manufacture, distribution, and its science will not all be in the global north. Thank you.
Thank you, Mr. Farrar. Please, first row for you. We will start now the second panel. By the way, I have not been infected yet, so I'm in your group. I hope this will not be the first time, as you anticipated. Please, let me bring in for our next panel, Mr. Amadou Sall. Oh, there you are. He's the director of the Institut Pasteur in Dakar. Welcome, and thank you for joining us. Ms. Girija Shankar, we've met already a couple of times. Thank you for joining us. She's the head of neglected tropical diseases of the Christian Blind Mission. Also, Ms. Cornelia Betsch, thank you for joining us. She's professor of health communication at the University of Erfurt. Welcome. Please take a seat here. Ms. Yuan Kyung, who we also already met, welcome. Ms. Hu, she is a senior legal and policy advisor of Access Campaign at Doctors Without Borders, and we also have a virtual guest this time. There he is. If I'm not wrong, he is in Washington, D.C. I'm not sure, though, if he's still there. He's the Director General of the International Federation of Pharmaceutical Manufacturers Association, Mr. Thomas Kearney. Welcome. We can see you already, and I hope we can also hear you.
I'm in Switzerland.
Yes,
actually.
you're in Switzerland now.
Washington
Okay.
and Kyoto.
Okay, welcome. Well, what we're going to talk about now is how to ensure effective access to medical countermeasures during the pandemics. How can we prepare for that? And I would like to start, Mr. Sall, with you by asking you, because you work in an institute that produces vaccines, so how can you assure accessibility to vaccines in Senegal or in West Africa, and especially in times of crisis, like in a pandemic or an epidemic?
Thank you very much for the question, and thanks for the organizer for giving me an opportunity to come back to Berlin and talk to all of you and meeting many friends. I would take that question by quoting a little bit what Jeremy has said. If you want to be ready, it has to be there before. Pasteur Dakar, and sometimes not enough. Pasteur Dakar have been manufacturing for 80 years a WHO pre-qualified vaccine, but still we were not ready when the pandemic was there. So it's very important that we think by design, by intervention, a system by which actually you can be resilient. So what I mean by that is what we learned from COVID is we need to build a capacity that gives us, when it comes to products, what we call the AAA, availability, accessibility, affordability. And by design, when it comes to products, that's what we should focus. The way we're handling that is to build a system where we have different platforms of manufacturing, and we build the whole ecosystem to be able to deliver that. When I say the ecosystem, it's not just about manufacturing capacity, but you need to have the R&D that would bring the vaccine that we need, because they are not there yet. Many of the diseases important for Africa are not there yet. You need to bring the regulatory and harmonize with other people, and you need also to make sure that you have the workforce development that is needed. I'm focusing on those just because obviously funding and all this is important. But today, funding is available. It's the accessibility to funding. Sometimes it can be very complicated in terms of process. Now, beyond the product, we need to have a delivery channel that is critical, and that's what we're building. When I say critical channel, then we're talking about triple S. It has to be sustainable. It has to be done in solidarity. And it is very, very important also, while we build this system, we are in a position to be socially relevant. So why I'm saying that? It's because usually we have the product, we didn't think enough about how to deliver that product. And several examples have been given. So what we try to do with IPD is to link what is happening in the public health of what happened daily, like the surveillance system, all this emergency, and link that to how you respond and how you could, from a sequence, go to vaccine manufacturing and development. And that's why technology play a key role. Today, when we talk about messenger RNA, this is one of the technology, as Jeremy mentioned earlier, where the hub and the strategy that is being built allow us to build some sort of public goods, where within the same project, different country and manufacturer are picking products with the commitment that this is going to be accessible globally. And each of us would develop a product that would help actually when these products are needed to be able actually to make it available to others. So these things, this sort of mechanism to build this public goods is very important. And I want to finish with something even more important. We talk a lot about trust and communities. Having worked for years in epidemic, communities have very good memories. But what we keep doing when we engage them and come with our product is teaching them. So we need, rather than teaching, learn. Rather than saying we need to listen. And whenever we build a solution, it should be co-creation. I'm an African. Every time when I go into even my own country, I learn from the community. This is not the way we understood this. So that part for me is something we tend to neglect, but which is even the most important part. Because when we talk about building trusts, where we come with lesson, where we come with vaccine, people reject them. And we have all this push. Don't need to lecture people about anti-vaccine movement. Vaccine confidence was very low in Africa. After COVID, it became huge because of all these medias and discussions. Even EPI now starts suffering from it. So these are just the 3 points I wanted to make about how we build a resilient system by focusing on the product, the channel of distribution, and make sure that the recipients are part of the solution. They own this process because they're associated from the beginning by listening with them and designing some sort of system through co-creation with them.
One more question specifically on Africa, because the AU, they want to produce 60% of the vaccines by 2024. How realistic is this?
I think it's very realistic. Let me give you some numbers if we have some of this project happening. In Senegal, we are 18 million people. Our project is targeting 300 million on full speed, so more vaccine than we can do, and have an option with some equipment and innovation to go up to 1 billion in terms of capacities to make products. So for me, I believe in terms of pandemics, what's going to happen over the next 2-3 years may help reach that target. Now, we have to be very realistic on that, on the fact that the major problem we face, me as an African, when talking about this project, is credibility. I'm not talking about credibility myself, but very few people believe this is happening. If today Germany say, I will be in 10 years in a position to make 1 billion doses, nobody's going to question it. So that's why we need to build some of those success stories. And I really think that if you take Senegal, you take South Africa, you take Egypt, you take Morocco, you have enough people, capacities, where if we focus properly, this is a target that can be reached. But I believe what also Winston Churchill was saying, we have to do it optimistically. And an optimist is someone who finds opportunities in difficulties. And not being too pessimistic, meaning that finding difficulties in any opportunity. So Africa should be more optimistic, changing that narrative by building some success story. And myself, I'm really working, and next year we should be online with at least 2 facilities, an R&D center, and human capital development, really online to reach that target. I think it's feasible. It needs partnership. There is some block on the road, but this is feasible. I strongly believe in it.
Are you getting enough support from abroad, also from the German government?
Yeah, I have really to thank the German government that committed to support us at a higher level. I mean, they're giving a $20 million grant, which is important and significant. It's very important for a group like us. We are a non-for-profit organization, meaning that our focus is to have impact. So many other partners are coming into that. But that's, for me, what matters. If we talk about 30 projects in Africa, I don't believe it's going to happen. But focusing on 4, 5, 6, well-designed, coordinated, from the portfolio to the research to the delivery, this is feasible. And the partner, actually, I think around the table are there, some of them very committed. As I said, what is really, really, really painful is the process. It may take 3 years to get the money, which in terms of today, most of these projects are collapsing because the critical path is on the money and the process to get them are really, really complicated.
Thank you so much. Ms. Hu, we've talked about the pandemic accord. So what provisions regarding the access to vaccines do you think we would need in that pandemic agreement?
Thank you. Also, first, thank you for invitation for MSF to be able to share our view here. So I would like to answer this question by telling a story about Ebola therapeutics that we are still following, which, in our opinion, elaborate what we see should be included in the accord. So Ebola virus is one of the pathogens with pandemic potential since 1970s. Out of 50 years, there's no R&D breakthrough in terms of bringing treatment therapeutics on the table until early 21st century, when outbreak was considered as a security issue, and then there's an increase of R&D funding. And in 2014 and 15, when the new outbreak brings more funding because of national security concern, we see the funding was concentrated with probably one government in the US. So finally, we got a new treatment. However, there is a missed opportunity to have any concrete condition attached to the public investment to ensure endemic country who actually participated the critical clinical trial in this process of R&D to also get access of the end product. And today, we see endemic countries are relying on donation. If there's any new outbreak coming, there's no technology transfer, there's no open licensing on intellectual property, and one of the companies are still seeking patent protection in African continent. As a humanitarian organization, we have no visibility of how many doses can be produced if any new outbreak comes in, and there's no global stockpiling to anticipate new outbreak. Then for us as an independent medical care provider to get a supply immediately and deploy to the population we serve. So this story actually for us summarizes our position in this accord negotiation. We need to go beyond the security concern when it comes to pandemic discussion. It's about people's life and death. So we need the government to have a binding commitment and rules established to coordinate, really to establish concrete stockpiling and allocation to prioritize the most neglected population in the first place. Intellectual property rights need to be relaxed, and there should be concrete conditions attached to public investment on research and development, so that the guarantee of access should be the consideration from day one, not at the end. So at the same time, we know, for instance, the Ebola therapeutics was developed by using the samples of the Ebola survivors from African countries. And at the end of the day, those contributions are not reflected. And there's no guarantee to say if the endemic country government support a clinical trial, if the survivor share their sample and blood, they will get a post-trial access. There's no benefit sharing agreement from the day one as well. We think this pandemic negotiation should reflect those as well.
Thank you so much, Ms. Sewell. Let me bring in Mr. Kearney. I think you would be the one to answer this question. How can the pharmaceutical industry contribute to a more equitable access to vaccines? Can you give Ms. Hu hope and an answer?
I hope so, but first maybe just to correct a number. You talked about 60% by 2040 for the African CDC. Actually, the objective was 60% by 2040, which means in almost 20 years. And I have to admit, I don't quite share the optimism of Amadou Sall. When you talk to John Nkengasong, the former leader of the African CDC, he's the first one to say this is aspirational, which means it's a scratched objective. I think the industry, and I listened to Jeremy Farrar, has done what it was expected to do during the fight against COVID, because innovation delivered in record speed and record scale up. And we were lucky. Few people talk about the risk of failing. Jeremy mentioned some of the scares about future pandemics, and I agree with his assessment on influenza. But when you look at the vaccine situation pre-pandemic, 3 of the world's largest vaccine manufacturers flopped, if you can say that. And we were lucky to have a pretty much unknown biotech company in Germany and another one in the US coming up with the mRNA vaccine, and the collaboration between Oxford University and AstraZeneca, and also the Johnson & Johnson vaccine. 85% of the vaccines used by COVAX for the low-income countries in 2021 came from 4 innovative companies, which means when I look at the pandemic treaty negotiations, we really need to make sure that what worked, the innovation ecosystem, which went back more than 20 years, is not compromised. And the access to pathogens, whatever we say about the need to increase surveillance, and I wholeheartedly agree with that, that worked too. And we have to admit that we all share part of the blame on the lack of equitable rollout. Now, as I sat on COVAX with civil society, with WHO, the Global Vaccine Alliance and CEPI, and when you look at what happened there, at the beginning, the plan worked out. African countries got substantial supplies of vaccines in mid-March 21. The same day, Japan got the first vaccine supplies in Tokyo. Then you had the Delta variant causing havoc in India, and Serum Institute of India, which was meant to be the largest supplier, couldn't export. That's why when I look in terms of the industry, one of the questions is affordability, accessibility, and availability. COVAX always had the lowest possible price, and many companies offered that for cost. US government donated at for cost. The problem was when supplies from India stopped, it took 7 months before supplies to Africa started again. And I think when we look at that, we need to focus in the pandemic treaty on how can we do better on equitable rollout next time. And for me, there are 2 solutions. One is we came up because we had a meeting of pharmaceutical CEOs in Berlin last year with the so-called Berlin Declaration. There, companies committed to putting aside part of available production in real time for rollout to low-income countries. And this commitment has since been endorsed by the developing country vaccine manufacturers, whether they're from India or from South Africa or from Latin America. But also when you look at what happened with the border closure in India, and they were never open in the US, we also need to say that we need to help on focus on how can we improve diversity of vaccine manufacturing geographically. And I had the privilege of being invited by the German government to many meetings of the Roundtable on Vaccine Manufacturing in Africa. I think that needs to be a joint partnership, a joint commitment. You need the private sector, as Jeremy and Mike Ryan and others have said this morning, but this is a long-haul effort. We need to pursue different pillars. One is, Berlin Declaration. How can this be brought into the pandemic treaty? And on the other hand, we need to work on how longer term we can improve the diversity of manufacturing. IP mentioned by Doctors Without Borders, honestly, every single vaccine manufacturer or therapeutic manufacturer from developing countries I talked to over the last couple of years said, this cannot be coerced. Voluntary licensing, 450 partnerships, does only work business to business, based on trust, and goes far beyond a license for vaccine. You need know-how sharing, you need joint training, you need skilled workforce, you need strong regulatory system, and that doesn't come overnight.
Thank you, Mr. Kearney. Of course, you're right, 2040 was the right number. That's what I wrote down. I didn't even notice that I said 2024. My apologies. Ms. Shankar, do you agree with what Mr. Kearney just said? Because we need medicines not only during a pandemic, but also during non-pandemic times. Are we prepared for that? Do you have suggestions that you would perhaps also address what Mr. Kearney said? Would that be enough?
Absolutely. Is this working?
Yes, it is working.
Brilliant. Well, thank you so much, first of all, to the German government for the invitation to participate in this high-level panel. It's not often that NTDs get included in these high-level panel. So thank you for including NTDs in a panel titled No Time to Neglect. And before we talk about that particular point, Carolina, I'd like to talk about access to medicines from the point of view of neglected tropical disease elimination and what we're able to celebrate thus far. So the success of many NTD programs, arguably, has been because of sustained public-private partnerships that have made medicines free of charge to countries that need them. Yes, these are medicines produced in the global north, and yes, we cannot rest on the laurels of donation programs, but it's definitely a start, and it's something that's worth celebrating because we have made significant advancements on the back of these commitments for drug donations. Let me give you a specific example. The Mectizan donation program is one of the longest running donation programs in the world. It has made the medicine Mectizan or ivermectin available to countries free of charge until river blindness is eliminated. And based on the success of this particular drug donation partnership, other programs have come about, like the drug donation program for trachoma that is supported by Pfizer. As a result of which, implementing partners like CBM, my employer, and Ministries of Health and the WHO and other implementing partners have been able to leverage these drug donations, bring in new investments, and really help countries advance to elimination. Just recently, we celebrated the elimination of trachoma as a public health problem in Malawi, Benin, and Mali. But I don't want to talk just about drug donations because a colleague here said, don't talk only about mass drug administration. NTDs are beyond that. So I would be remiss if I did not call for a resounding recognition of an investment in NTDs going a long way towards universal health coverage. I would say that NTDs are arguably the best buy in global public health. By some estimates, an investment of $1 in NTDs could give you anywhere between $27 to $42 for economic benefits. So that's definitely something worth considering. And because we're talking about pandemic preparedness, I do want to note that, as Minister Schulze said, there has been a backsliding in NTDs because of the COVID-19 pandemic. And many countries that were on track to eliminate disease will no longer be able to reach their 2030 roadmap targets. But having said that, I do believe that NTDs can be a bellwether program. NTDs are a litmus test for universal health coverage. In many rural and isolated communities, NTD control and elimination programs are often the only touch point that such communities have with the health system, so that can be leveraged for pandemic preparedness. And finally, several of the measures that we use to prevent and manage NTD, such as water, sanitation, hygiene, and health education, can be leveraged for COVID-19, which we are, and for future pandemics. So I may not have necessarily addressed his remarks directly, but I do want to make a point to say that the experience from these last mile programs, such as NTDs, can be leveraged to respond to future pandemics.
Thank you so much, Ms. Shankar. Let us imagine for a second that we have this universal access to vaccines. What happens then? Because there's also a vaccine hesitancy, right? Ms. Betsch, perhaps you want to comment on that. What do you do with people who are hesitant to take the vaccines? That would be the next step.
Yeah, that's an excellent question. And I would also like to thank the organizers that they had put this social and behavioral science perspective on the panel. And Minister Schulze said in her learnings from the pandemic, the first learning was about communication and action. And actually, in the German pandemic preparedness plan, communication was 0.9, so it was the last chapter in the pandemic preparedness plan. And so I think this was one of the learnings from the pandemic that, as you said in the beginning, that we should consider these kind of questions, how we have the vaccine, so would everybody want to have it? And if not, why not? How we can implement the research that is done in the field to improve access. So I think it is good to expect that not everybody would want to have the vaccine. This is what you need to expect. And then you need to find out. So you have to do research. And as Jeremy said, I think there is also a very great need to do basic science in communication, in social and behavioral research in non-weird countries. Because I'm a psychologist, and most of the theories and findings we have are from weird countries, Western, educated, industrialized, rich, democratic. And there's nearly no research from other basic research from other parts of the world. So we think, we understand how humans behave, but this is just from a very limited part of the world. So I think this is very important, and I think WHO has also recognized the importance. WHO Euro has just recently put forward a resolution on behavioral insights to strengthen health for all. And I think this is something very important because the countries agreed to use behavioral insights, what we know from social and behavioral research, to improve health systems. And I think this is something where each health system can really profit from this. And because it's, there is a lot we know about individual factors why people don't want to get vaccinated.
What are the main reasons for that?
Well, lack of confidence, trust, yeah. And there is lots of research done showing how you can train health workers, for example, that are still the most trusted resource of information. How can you train them to fight the infodemic that was also mentioned a couple of times? So there is good evidence that needs to be implemented. And I think this is one of the most important things we know from the pandemic and what we can do now after the pandemic to implement all the stuff we've learned so far to improve the health systems. And I think when we discuss health here, we tend to forget that health decisions are sometimes not just health decisions anymore. Because during the pandemic, vaccination turned into something very important for people's identity. Many people identify with being vaccinated or not being vaccinated. And this contributes to the populism, this contributes to polarization, and this makes it more than a health problem. And I think, integrating behavioral and social science into the processes can help understand vaccine hesitancy, can help bridging gaps, and I think one of the most important players in this are, of course, healthcare workers, and there is much work done to improve the conversations they have with patients, and a lot more, which I cannot touch upon. Yeah. But I think implementing the research that is also locally done is very important to have tailored solutions.
Thank you so much. Indeed, it was very interconnected and became even a political tool based on the political identities, as you just mentioned. I would like to open the floor for questions from the audience. So I would take 2 questions, perhaps 3. Is someone in the audience who wants to ask a question for our guests here? If not, then I might ask the virtual guests. Go ahead, please.
Thank you very much. My name is Willem Broek. I work with Fine Diagnostics. I'm interested to hear the panel. There's always a lot of attention on vaccines. I think, as Jeremy said, we understand that vaccines are an important tool, but we've also learned that we can't rely on vaccines on its own. I'm interested to hear how diagnostics play out in the same type of area. I know, Amadou, you're also setting up a diagnostics facility. Thank you very much. And how that is different from working on therapeutics and vaccines and what that means for programs.
Yeah, thank you. Thanks for giving the opportunity for this diagnostic, because diagnostic is so important in the sense usually that's the entry point for the health system. For that reason, I think if you look today, diagnostics, there is many of the tools that would really change the whole landscape of surveillance if you have like even very simple rapid diagnostic tool at the most remote area, meaning last miles. So that's why we start a pilot project that turned out to provide one of the first COVID rapid test vaccine, a rapid test for diagnostics in Africa and sold in all West Africa, was really the purpose that was access. Came out with $1 while most of the other tests were more than 5 or 6 or even more than that. So what this means is that if locally people are addressing the needs with the right model, because we did that with a very specific business model, this is something feasible. And today, beyond that, we are tackling all these other rapid tests like yellow fever or measles rubella. Believe it or not, these are in shortage all the time. And this is very, very important to detect this epidemic and control. And we're building all this companion strategy between vaccine and diagnostic because most of the time they go together. So once again, it is extremely important. You should target really the primary healthcare level. And this is also one very important lesson that we learned. We had very limited capacity, and now we're expanding thanks to partnership we're having with FINE and other players to be able not only to tackle epidemic disease, but major vaccine need, diagnostic need like for malaria, for HIV, for syphilis. And this is for me quite important for the health system.
Ms. Hu, you wanted to add something on that?
Just quickly, because I think diagnostic and therapeutics are super important when we talk about PPR. It's not just about vaccine. So when it's come to diagnostic, 2 points to maybe also reflect to the discussion about voluntary measures, Berlin Declaration industry mentioned. For us, there's a concrete example also we are working on right now with a company called Cepheid, who got exclusive public funding and developed a testing system called the Gene Expert. So that system can be used to detect TB, hepatitis C, and COVID. But the company has not made any effort to make the technology available to countries who are needed. And then the price is very high. We're still going after them after more than 10 years of time when the product is in the market. And the company actually increased the price during the pandemic when the system can be used to detect the COVID. The interesting part of that story is that if we really rely on industry's voluntary willingness, there's inherent limitation how much they can do, because there's a market dynamic behind their thinking, which may not always match with the public health needs. Even though, so that's technology-wise, from what I learned from our in-house expert, it's not super complicated if you have the access to those know-how, those information. It can be replicated. It can also be developed further to use a system, detect the different diseases, which will be more efficient. Different from you develop one system for one disease, another system for other disease. But if you use a system, use the same machine, detect different diseases, but you need to develop the different the tool for that. So that brings us to again the point of technology. So what kind of rules need to be there to make sure that, yes, on one hand, we have the scientific progress and innovation, but on the other hand, people need to access to those technology so that they can take care of themselves rather than relying on voluntary measure of big player. And plus, the voluntary measures are limited. I mean, we acknowledge, Dr. Cooney, Mr. Cooney mentioned more than 400 partnership, but there's no starting point of talking about that because there's no transparency to really know what's been signed, what are the partnership. So in the COVID, we know WHO-backed voluntary measure. There's 3 major voluntary mechanism backed by WHO and the member states, and medicines patent pool, and the COVID technology access pool, and mRNA technology transfer hub. Industry did not come through. So far we only have 3 licenses and MPP. None of them actually up to the standard for the pandemic.
Okay.
Nobody joined the vaccine technology transfer hub, for instance.
All right.
So it's not enough.
Thank you, Ms. Hu. Because you were mentioned, Mr. Kearney, do you want to add or respond to that comment?
Yes, I would like to, because actually in the vaccines area, we had lots and lots of voluntary licensing and tech transfer, more than 300. But also we saw the complications of vaccine manufacturing. We saw the risks of mRNA. For example, you in Germany know there were 2 companies hyped in terms of mRNA. One never made it. There were 23 mRNA projects globally in industrialized country. Only 2 made it. But there was a lot of voluntary tech transfer. And in the therapeutics area, we saw the medicines patent pool used widely on antiviral medicines. And we had a meeting, for example, with the DG of WTO, where you had license takers from developing countries. Their concern was actually the competition from unlicensed manufacturers. Their concern was the market, which was not big anyway, was compromised by substandard, sub-quality, poor standards. And I think we should not underestimate the challenges of GETS sustainability and resilience. I was earlier this year absolutely shell-shocked, almost depressed when I saw that one of the companies which had built up vaccine capacity in Africa, BioVac, and had a collaboration with an innovative manufacturer on pneumococcal vaccine. And after years where they had manufactured and supplied that vaccine in South Africa, the government opened this for tender. And surprise, surprise, there was an Indian competitor which offered lower prices and the local manufacturer lost out. That's why I do believe if we are serious about regional manufacture, we need to engage with organizations like Gavi, the Global Vaccines Alliance. We need to accept that subject to quality not compromised, these local manufacturers may need some protection against, cutthroat competition. I don't think the competition will be from the big innovative multinational, but we need to make sure that quality is not compromised, that the local skilled workforce is there, that the strong regulatory systems is there. And we do not see, issues such as South Africa saying, oh, Cipla and Serum Institute are cheaper. We don't care about BioVac. I think we need to have some honest conversations on this.
Thank you so much, Mr. Kearney. Ms. Batch, you wanted to add something? Was it on this? Not on this topic, okay. So I would take one more short question and a very short answer, and then we would wrap it up. There's a hand going up for a long time already. Sorry, I can just take one more. Thank you so much.
Hi, I'm Melissa Schavai, also working for MSF Doctors Without Borders, and I want to touch on a different topic that we would like to see in the pandemic treaty, something related to what Mr. Farah mentioned earlier, the investment in basic science, which he said is important, and we only have what we need in a crisis if there was basic science and investment in that. before the crisis, and we agree with that, and also think that there should be, for the public funding that often comes along with science, research and development of medical counter tools, that there should be conditions for equitable access, for example, for sharing licenses, for sharing know-how, and beyond to this public funding. And this is a tool that should be part of the pandemic treaty, and concrete conditions to that funding in science should be included from the first moment, so that we do not come into a lot of the difficult conversations during a pandemic. So ideally, I would like to ask this to public funding givers, such as the German government, but you're not on the panel. So I thought maybe someone else, Mr. Sahlen, maybe would have thoughts on this, or someone else from the panel. I would like to hear views. Thank you.
Thanks for that question. Do you have a short answer for that? You would confirm it. Okay. Well, let's wrap it up with your comment. Thank you so much. Let's finish the second panel, sorry. For now, we still have one more panel. Mr. Kearney, also thank you so much to you over there in Switzerland, and thank you to my panelists. We've already heard him in the first panel, Mr. Jean Casella. We are keen to hear your words. Please, the floor is yours.
Thanks, colleagues. I missed the comment from Jeremy. You know, when I'm somewhere, everyone wants to meet, bilateral meetings and and then I had some meetings with some key people. I'm so sorry, Jeremy. You will brief me later. But colleagues, this is really an opportunity for me to thank all of you for giving me opportunity to discuss about this discussion on the IDS and the public health intelligence and how we are approaching that in Africa. You know, based on the lesson learned from COVID, we managed to make significant progress. We got not only support from partners, but the willingness from our member state to move forward with the agenda of IDS. And we have 47 countries in Africa who adopted the IDS, and that generated a lot of results. The first one, let me give you 4 or 5 key results that we got. The first one, the surveillance system for all priority diseases are now integrated in 47 countries. We are talking about 55 countries in Africa. It means we made a lot of progress. Before that, before COVID, it was only 15 countries. And today, we have also the surveillance and response processes across all our member states are standardized. It means we can discuss the result that we are getting from each country. We have also data for all priority diseases that we can have some time, we can get it timely for some of them, but it's also about the completeness of this data. Despite some of this improvement, we still have many other challenges, many. The first one is about what I call the technology, the digital technology. We have only 10% of our member states who have optimal capacity to electronically capture, analyze, and disseminate data. When we talk about 10%, let us talk about 5 countries out of 55 countries. You can imagine, we still have a huge gap. This morning, I was discussing with a number of colleagues, and even now, the meeting that I have with the 2 DGs, it was to discuss about how we can strengthen this agenda of digital health digital platform in Africa. The second one I can raise is about the One Health approach. How can we strengthen the One Health coordination mechanism, not only at continental level, but also at country level, and to link all of them? We need the system to talk to each other. We need each country to talk to another one. We have so many issues regarding the One Health. Mostly we are targeting the human, but the animal one, we are not doing too much. And we need to strengthen that. We have framework, we have policies, but we need really to move from policies into action. We are also talking about the workforce. Less than 10% of our countries are able to respond adequately to a major outbreak. But when I say less than 10%, I'm talking about 4 countries with adequate human resources. And we need to deal with that. How are we dealing with that? Now we are empowering the community health workers. We have a new approach. For colleagues who will attend the World Health Summit, you will see USAID, UNICEF, Africa CDC, and a number of other partners. We are launching what we call the Community Health Delivery Partnership. And you know that in Africa CDC, we have this program of 2 million community health workers, because we believe that community health workers can complement what health workers are doing. We believe that they will become part of what we call the health workforce. That one is still a challenge. And let me also say that when we talk about event-based surveillance, we don't have any member state with optimal EBS. And this is a major issue for us. Then we are thinking on how we can approach that. When we are talking about all of that, we are also talking about the hope that we have. What is this hope? The hope is what we call the new public health order. This new public health order is our blueprint, is our vision for the future, the long-term strategy that Africa has. This new public health order will help us if we fully implement that to address a number of issues that we have. We believe that with this new public health order, we can strengthen the One Health multi-sectoral coordinating mechanism. But when we are talking about One Health multi-sectoral coordinating mechanism, we are talking about PPPR, because we are bringing also the agenda of local manufacturing. We are bringing the agenda of human resources. We are bringing the agenda of regional and national coordination mechanism. We are talking about the National Public Health Institute. You can imagine, I come from a country, DRC. This country, you have outbreaks every week. But almost every month, they are creating the ad hoc committee to deal with outbreaks. There is no institutional memory. By having a strong National Public Health Institute, now they will start to deal with outbreaks by having this institutional memory. This, I give you that case, but we have a number of cases. Today, we have only 15 countries with National Public Health Institute in place in Africa. It means we still have a way to move forward. And we hope that Africa CDC, with the new public health order, we are also developing the robust governance procedures, how to manage all of this public health threat that we have, how to ensure that we have accurate data, because data is the main issue today. And we know also by integrating our surveillance system, we'll reach there. The most important for us in Africa is to have information and to know how to deal with that. Outbreaks will occur. Diseases will be there. But having information, knowing how to deal with that, having tools and having strong system to support implementation of these two, this is what we are dealing with in Africa. I think I wanted to thank all of you for this discussion that we had today. I wanted to tell you that we are so motivated. We are not disparate. We are so motivated by everything we see, and we know that we are working together. And we can count on your support, technical support, strategic support. I don't want to talk about financial support, but yes. And with all of this support, we know that we have capacity to deal with issues. in Africa, what we did so good, now we have the political willingness to address all of this public health threat. Now we have a strong Africa CDC leading the agenda at continental level, and we have also WHO, UNICEF, and other partners working with us. I think this is my hope that I wanted to share with you, and I hope that we'll continue this discussion in the next 10 days with the World Health Summit and other opportunities that we'll have. You have to know that we are moving the agenda in Africa. Thank you.
Thank you so much, Mr. Kaseya. Very optimistic words indeed. Give me a second. He already gave us the kick-off words and a speech for our next panel. We will be talking about surveillance and how we can identify measures to make more collaborative surveillance around the world and share data. So please let me bring in our guests, Mr. Chikwe Ihekuatsu. Where are you? Oh, back there. I was afraid that you just disappeared. Thank you so much for joining me at the stage. Okay, Mr. Simon Antara, there you are. Please join me on the stage as well. Take a seat. So, he's the director of African Field Epidemiology Network. And Mr. Ihekuatsu, you all know him. He leads the WHO Hub for Pandemic and Epidemic Intelligence. Ms. Pilar Hernandez, please, we already met as well. She's the managing director of SORMAS Foundation. It's okay. Sure, take a seat here. Ms. Johanna Hannefeld, please. She's the head of the Center for International Health Protections and also vice president of the Robert Koch Institute, Germany's National Public Health Institute. And Ms. Marion Koopmans, she is joining us virtually, isn't she? We can see her name, not her face yet. She's the director of the Department of Viruscience at the Erasmus Medical Center in the Netherlands. Will she be joining us? Can someone give me a sign? She's already listening to us, but we can't see her, right? Okay. Can you give us a word, Ms. Koopmans, just to make sure that you're there? Okay. Let's start the round without our... No, it's not me, Mr. Kearney. We can start talking about this, and let's see if Ms. Koopmans joins us after that. So, Mr. Ihekuatsu, there is a WHO Intelligence Hub, and we have already mentioned it in the other panels, and that was established in the midst of the pandemic. So, how can this hub fulfill the mission in really supporting countries to address further pandemics in the future, and especially risks, and also how to access data and share the data?
Thank you. Let me start by, reflecting on the incredible courage it took to set up the hub at the time it was set up. Because you have to imagine we're still literally in the middle of the pandemic, right? And I think because of the shared experience that we had around the world, in just not being able, feeling disabled in our ability to make decisions at the rapidity, flexibility, and agility needed, which was a shared frustration around the world. So it took an incredible amount of courage and collaboration to make that happen. And it's that collaboration that is almost mirrored today, seeing the Ministry of Development and Health working together on this. And as much as the hub is a hub for pandemic intelligence, and you framed your question around data. The biggest, we don't have a challenge, literally, with the technology available to share data. We have a lot of that. We need to get some into the health space. Our biggest challenge is trust. It's how we get ourselves to work with each other in the spirit of understanding the shared vulnerability that we all face. So I think our biggest challenge, and something we've been trying to also translate to our member states and countries and regions around the world, we don't have a technology challenge. We have a challenge of how to work together. And very often, We think that that hasn't happened in other sectors, but there are many sectors, and I can count a number of them, whether you think of aviation, finance, maritime, where people share data on a daily basis, even in confrontational situations with different countries. So somehow the data that we need to make public health decisions on a daily basis has somehow been sacred in our need to keep it within our own system. So a lot of the work we're trying to do is take the sacredness out of health data and again, come to a common understanding of why we need to do this. And once that's, I think that's beginning to happen. And many countries are beginning to see why it's important. We're not quite there yet. But really, the more we can do that, I think the technology, the human, the innovation, the systems, the type of work Pilar is doing, and many colleagues around the room will emerge as long as we can enable the ecosystem and this understanding that really, like our DG always says, you know, this is not a problem any one country can solve for itself, but one we have to work on together.
So trust as a priority. Ms. Hannafeld, would you sign that? What is also trust the priority? You see the main challenge?
Yes,
building trust.
I couldn't agree more. I think so. I think this is one of the key, Chikwe has rightly said, and I would say one of the pleasures of having the hub here is not just the capacity it provides for the world, but also the excellent working relationship it allows us and it allows colleagues to work together throughout the world. I think trust is essential, and I think it is around the data and the data sharing that allows us. We heard earlier about this the golden moment from the identification of what can be an outbreak or an epidemic and preventing that. And I think the real lesson, or one of the very big lessons for me, is that the trust is something that, again, you can't rely on that during a crisis, right? It's something that you build before a crisis, and that's why. A symposium or a high-level forum like this is so important now, so that you say you need the investment during peacetime to build that kind of trust architecture, and you need to have an infrastructure, and that's where both the national structures, the national level structures like national public health institutes are so important, but also the multilateral system, and that working together sort of in a symphony. So we need to strengthen the national structures during peacetime at all times. And we need that networked. So we need to come together, we need to work together to build that trust architecture.
Trust, but also surveillance, right? We have been already touching on this topic in the different panels. And how that is also a priority, I understand. How do you ensure that? How do you work towards that goal?
Yeah, so I think Chikwe put it nicely to say we've got the technology in a way, and then Mike Ryan had this about the glass of water, right? So it's about, it's not so much about the hardware or the software being lacking. So I think we have a lot of good surveillance systems and a lot of strong surveillance systems and a lot of solutions. But one of the challenges at the moment is that it feels a little bit like the Wild West. So there's a lot of different solutions, and there's a lot of solutions that come maybe also with a commercial interest, and that are essentially marketed. And each of these are beautiful in their own way, or most of them are, and they have a value. But the challenge is that we need an integrated system around the world, right? So Jean was talking about the system on the African continent, and it's great the strides that have been made to integrate that surveillance there. But we need data systems that can talk to each other. We need some type of regulation, and that's what's lacking at the moment. And sorry, Chikwe, to push you or put you on the spot there a bit, but one of the things that I think for people like us was so exciting about the hub being or coming into being, and the work that the WHO is now leading around this, is that in a way it can offer a standard or some type of regulation around saying what kind of surveillance systems work for the world, so that we can have systems that speak to each other at all times. And that's just as important as having, of course, it starts with the community, right? And then with the national system that captures the different communities. But you also need that networked across countries, continents. The regional level is really important. I don't know where Jean is gone, but anyway, regional level is really important, but also networking that globally. And I think at the moment, we are in this window of opportunity. There are a lot of solutions, and now we need a little bit of coordination and alignment.
to have also a common base, like for example, equally trained health workers. That would be also an important element on that, right?
Well, health workers are well, I don't want to say the be all and the end all, but I think one of the other big learnings, so I think if we say trust is a key learning, and you need the national structures for that, and you need them internationally networked. And I think the second aspect is that for sure the frontline public health workers are absolutely crucial. And I think we've seen that, and I think we've also seen that that is still quite a scarce commodity, right? So that is really something that needs to be strengthened as a workforce. And I think there are very strong aspects where we can build on. One of them I want to mention is the field epidemiology program. So we're very proud to have the German field epidemiology program at the Robert Koch Institute, but we're also proud to work with our brothers and sisters around the world in strengthening these, and the colleague from AFNET is here, and the global network TEFINET, and we're going to launch a global partnership around this. That's one of the aspects where we can really invest in that frontline health workforce. There are then other mechanisms, I just want to mention them briefly, which again network this capacity globally. And we've already got some good networks that work in practice. So we've got things like GORN, which bring individuals in outbreak situations into regions or countries where that capacity is lacking. We've got emergency medical teams who do scalable clinical interventions. And we've now also, with the Global Health Emergency Corps, got the idea of really building a scalable capacity. And again, regional approaches there are very important, and Jean mentioned that in his keynote also. So I think really important, that workforce element to make the surveillance work. And I think despite how far we've come in the last 3 years, that is still, for me, perhaps the biggest building block that needs to be strengthened.
Thank you. Ms. Hernandez, SORMAS is an IT tool, but not only that. Is that also part of a possible solution for a surveillance instrument?
Yeah, absolutely. So I just want to, resonate on the words of Hannah and Chikwe. The technology is there. So SORMAS, so just for people who don't know SORMAS very well, is an open source software. It's a tool, and the unique selling point of SORMAS compared to other surveillance systems is that it fills exactly this golden gap that Minister Lauterbach mentioned this morning. This early detection of outbreaks to avoid these outbreaks to become pandemics. But the thing is that we have the technology, but the technology is not magically run.
We have to get people to participate.
Exactly,
and to put in their data.
We need people, human resources that will be running this technology, that are using the tools, that have to be trained. We need hardware. We need the servers in the countries to host the data, etc., etc. So yes, it is, but it's a technological solution.
How do you get there, Mr. Antara? How can you build that trust also with the communities in order to get them to use this kind of tools?
Well, first I'd also want to thank the German government for inviting my organization, AFNET, to be part of these discussions and to put on this discussion the very important issue of human resource. Let me respond to the question by bringing in some context. We have more than 100 emergencies reported annually from Africa. We are experiencing the effects of climate change in the form of floods and in the form of drought in parts of Africa. We have conflicts as seen in Sudan and in the Sahel region of the continent. There is resurgence of vaccine-preventable diseases, something that Dr. Mike Ryan referred to this morning. And this is seen in the number of cases of measles. This is seen in the number of cases of diphtheria, something probably you have not heard about for a long time here. These cases are being reported so much from many countries. We also have cholera outbreaks. Now, we also have the circulating vaccine-derived poliovirus, widely reported from many countries. And as if that is not enough, we also have a very high burden of non-communicable diseases. Now, we need to juxtapose that with the health workforce situation in Africa. And we need to look at the statistics. The finding that Africa, which is home to 11% of the world's population, bears close to 25% of the global disease burden and has only 3% of the global health workforce. That is an emergency that must be addressed. If you look at the Global Health Security Agenda targets of 1 epidemiologist per 200,000 population, Africa, with a population of 1.4 billion, should have at least 7,000 epidemiologists in its health system to impact it. At the last estimate, what we found is that the number of epidemiologists, field epidemiologists that have been trained, is only a little above half the minimum target. Now, I think this is an emergency that we must address even before the next pandemic. As we have said, health workforce is at the forefront of everything. My colleague on the panel here did not want to say the human resource is everything. But of course, whether we are talking about technology, whether we are talking about all the international conventions and treaties and frameworks, IHR 2005, universal health coverage, the Sustainable Development Goals, health system strengthening, all these have implications for human resource. And without human resource, we cannot move forward without these things. Now, the gap that I've just talked about in human resource in Africa, it has implications for surveillance. It has implications for public health disease intelligence. And it has implications for public health emergency response. Indeed, it has implications for national, for continental, and for global health security. And I think that this is an emergency that we must all work on and address as quickly as possible, even before the next pandemic. Now, AFINET is one of the regional networks in the world that supports field epidemiology capacity development. We work in sub-Saharan Africa, and we are present now in 40 countries, working to establish and to support the maintenance of workforce development for advanced, for intermediate, and for frontline training programs. In our trainings, we want to make sure that the graduates that are coming out of these programs are very conversant with technology such as TOMAS. And indeed, AFINET has been part and parcel of the implementation of TOMAS, and even at the very beginning of its development, AFINET has been part and parcel of it. But I want to say that it is important for us to situate our workforce in a manner that addresses national needs, in a manner that addresses some of the global interventions, some of the global frameworks, IHR 2005, universal health coverage, health system strengthening, sustainable development goals. It is also important that even as we discuss workforce, we take into consideration, and I'm talking about Africa, the AU, the African Union's Agenda 2063, and the need for a healthy population to bring about the socio-economic transformation in that agenda. We should also take note of both the recommendations of both the G7 and G20 on creating a global health architecture that is well equipped for future epidemics. Now, considering all these things, we have a huge responsibility to address the workforce gap that exists in Africa. Many people have said here that what you have before a pandemic is what you have. And this is a good time for us to look at investing in workforce development. Indeed, funding for workforce development has actually gone down. As we talk about preparing countries, it is important that we begin to look how can we work together to address this emergency, the workforce situation in Africa. Thank you.
Thank you. That's about the workforce that also has, in a way, a responsibility when it comes to data exchange and collecting data. Mr. Koopmans, we can see you now. We missed you at the beginning. It's good to see that you can hear us as well. Perhaps you want to jump into this very point. How can a political coordination, facilitate data exchange nationally, but of course also globally? That's what we're looking at.
Yes, that's of course a key topic. And what I heard some of the conversation before, which of course is critical, but I like to add the dimension of One Health. If you really look at that in its entirety, it also means bringing in data types from very disparate sources. So it's about an environmental, ecological, data on food animal, data on wild animals. So I think a key issue there is understanding the ecosystem and expanding the discussions to include partners in that ecosystem that you need to have on board at one point or the other. What is clear from also studies that have been done is people are very much motivated if there's a workforce, but seeing the complexity of all the data that needs to be brought together can be difficult. So there's barriers because of that, because people don't see why anyone would need their data. There's interests. There may be interest in terms of publishing, and that can be in the whole sphere, that can be in public health institutes as well as academic partners. There may be interests in data that can lead to some kind of valorization. So I think it is critical to really understand that ecosystem and the partners that it involves. So that is well beyond the public health sector. It really is a multi-partite partnership that needs to buy into this common goal of, combining data for the global good. That to me is a key element, which is absolutely challenging. But a lesson as I see it is to not think that it will be solved from one pillar of the ecosystem alone.
And then another challenge is, Ms. Hernandez, getting people motivated and creating a community that is active, participating and sharing their data. Do you have an idea how would you do that? How are you planning to do that? Are you already working on that?
Yeah, we're already working on that. So in the case of SORMAS, the thing is that it's open source, right? So, and something that it's open source, sometimes it feels like it belongs to everyone, but it doesn't belong to anyone, right? So you just need an organization behind that will do the work of bringing the community together, fostering the community, fostering the exchange between sectors, between countries, because we are talking at different levels, right? We are talking about countries, we are talking about sectors in the sense of One Health, different levels within the same country. So, but this doesn't happen magically. So it's just not, people will not spontaneously start talking with each other and trying to share with each other their data or come to agreements on how to approach things. So this has to be obviously fostered by an organization. So in the case of SORMAS, obviously, like I would see WHO like in this kind of role at the higher level, but in our ecosystem, in our SORMAS ecosystem, that's one of the main tasks, or actually the main task of the SORMAS Foundation, trying to foster the ecosystem that is very diverse, that it's where we have users, we have researchers, we have IT companies as well that are developing on SORMAS. We have like a very diverse community. So really, so to the point, it doesn't happen magically. You need an organization behind with a team and a lot of work.
And then there are different levels. You're talking about the users now, but then there are the nations. How do you get the incentive for the nations to share their data? Mr. Ikewatsu, perhaps you want to... answer that question.
This really is at the heart of a lot of what we're talking about. You know, we have to think about the incentives we create. So the pandemic fund was referred to this morning, and it's really one of the biggest opportunities in global health for a long time. And surveillance was prioritized as one of the kind of priority areas for countries to apply for, right? But you know what happens when you ask 194 countries to apply for opportunities to do something. You get 194 applications of different ways to peel an apple, because everyone thinks they know have the best way to do so. So I think there are spaces that require global coordination. They require norms, standards. They require us coming together and agree this is how we want to measure diseases. These are platforms we use. These are technologies we apply, and this is a way of working. And that's really at the heart of what we're doing in the hub. And we call it collaborative surveillance because we don't want to insist publicly that you do it one way. We try and bring people together to collaborate using the same standards. And, Johanna is a lot more eloquent than I am and used the word symphony. And, you have to really think how an orchestra plays, right? The symphony that is produced out of it. And that's how the aviation industry works. No country, we don't tell 194 countries to create their own aviation space. Airlines will be bumping into each other. We say, listen, you have to come together through an IATA and agree on how to share data with the One Health community across countries, across disease areas, across all sorts of variables. And if you don't do that, then you end up in a Tower of Babel situation. And so that's really the good news, is that's the basis of some incredible work happening here in Berlin, at the hub, and whether it's on genomics, whether it's on data sciences, on all aspects of the work we're doing. We've started work on this, pulling countries together, sharing this almost, like I said, is winning hearts and minds over, because WHO can't insist on countries to come together. We appeal to your conscience that the only way we can work together to keep the world safe in this space is by working together on creating the norms and standards, technology, applications that we need to keep the world safe.
And creating common standards. Ms. Hannafeld, do you want to add on that? Is there a certain project you would like to highlight?
Well, actually, we have some specific projects with the hub which demonstrate this symphony, I think, quite nicely. So, for us as a national public health institute, we have a community of other national public health institutes. So we work also bilaterally through programs funded by our Ministry of Health, for example, to strengthen our brother and sister institutes all around the world, including in Africa. And but we always do this in collaboration with the multilateral actors, foremost the WHO. And now we have a joint work program with the WHO hub, where we use our bilateral partnerships in countries, in selected countries, to bring some of that expertise and work at country level at another national public health institute to learn together how we can use some of these tools we've learned about. So collaborative surveillance, what does that mean in terms of using genomics technology for your surveillance in practice? And not just what does it mean in terms of learning the technology in the wet lab, but what does it mean about analyzing that data and then using that bioinformatics data to understand give the type of policy advice that you need to your policymakers, right? And some of the challenges are very different if I go to Cote d'Ivoire or if I go to Namibia, and some of them are very similar to what we do here in Berlin in the RKI. So there are some practical examples of what we can do. And I think the real beauty of that type of collaboration is that because not only do we do this bilaterally, but as part of a multilateral partnership, this learning then straight away influences what happens at global level. So it's not very far away from the Chikwes, from the Mike Ryans of the world, because there is this kind of mutually beneficial, or this communication loop in a way has become much closer. So I think that's really important, and that's a concrete example. I think one additional thing I want to say is and that to just gel with the positive sense of this afternoon's conversation is that we also have these immense opportunities now with the technology, right? So the application of AI to this field of collaborative surveillance is scientifically fascinating, which means it attracts the brightest minds, and it will help us. It will help us solve these, hopefully prevent the next pandemic, but really address these challenges. So I think there's huge opportunities, there's energy, there's trust, and together we'll hopefully manage to do that symphony.
Very optimistic. Thank you so much. Ms. Koopman, I have the feeling you wanted to add something on that. If not, I would open the floor for a question from the audience. Okay, so questions. I see a hand there. Let's start there, please, and then we go to the center.
Thanks so much. Tim Büter, Hochschule für Politik at the Technical University of Munich. I want to raise 2 points, if I may. The first one is about the term surveillance. We've been doing a lot of behavioral research at the TU Munich, and in part as part of a EU-funded project that allows us to do comparative research around a bunch of European countries. And we find very consistently that trust or distrust of government is a huge determining factor of people's willingness to be compliant with health guidelines. It's also a major factor in their willingness to share data, and here particularly privacy concerns and concerns over app use are a big factor. Surveillance, I'm afraid, conveys to many people around the world exactly this kind of overpowering government that is likely to make abusive use of their data. I would strongly urge you to drop that term and replace it with something more constructive, whether that's monitoring, information sharing, or whatever else. It's going to have the wrong connotation. And let me very briefly also then speak briefly to the other issue. We also did research on people's willingness to support the vaccine donations to the Global South. And we did that largely because we had the sense that the hesitation of many northern governments to support that was grounded in a sense that this would be politically unpopular. Now, the good news is that across 6 European countries, in 5 of them, you had, all else being equal at least, a clear support for vaccine donations to the Global South. In part, it seemed to be based in actually understanding that there would be a sort of larger global health benefit. But whatever the reasons may have been, there is political support for it, and so governments may have been a little bit more courageous. Maybe they will take this as a lesson for next time. But there were 2 exceptions to that finding. The first one was that people who were themselves in a high-risk group were much more skeptical. That can probably be addressed with good communication. And the other exception, apologies to the hosts of today's events, was Germany. And I don't think that was because the Germans necessarily were less generous in their attitudes towards global health, but because for various technical reasons, we ended up actually doing the analysis in Germany about a month and a half, 2 months earlier than in the other European countries, when in Germany there were still widespread shortages of the vaccines, and many, including in high-risk group, had not yet had a chance to get even the first shot. That seemed to have played a role. Now, that playing a role in a hesitation of governments to support vaccine donations is just simply good politics, if you want, whether we like it or not. And so government's selfishness does have, it seems, some perfectly sensible political rationale to it. So my question is,
Thank you.
What do the institutions actually need to look like to give governments an incentive to do this, even while the domestic politics is going to pull them the other way, to actually cooperate and share resources? Thank you.
Thank you for the comments. Interesting indeed. Do you want to address the question, Mr. Hirotsu?
Obviously, I don't have a clear answer for this, but I completely recognize the conflict with the word surveillance, especially the way it's used in many other sectors, in the intelligence sector, and, all sorts of other sectors use the same word. And first thing, we have to be more intentional in putting public health surveillance. I don't know if that helps before surveillance and use it consistently all the time. But it's a fair point and one to consider very deeply, whether we can find a more collaborative term as we do the work that we do. But perceptions matter. You know, no matter what we think as scientists, words matter, language matters, narratives matter, and it's important to shape that. So thank you very much, colleagues from Munich.
Especially because the whole narrative around the pandemic was also strongly politicized all around the world, right? So indeed a very interesting comment. Thank you for that. Do we have, we had one more question there in the center, please. Yes.
Thank you. Yeah, I'm Katharina Haug from Imperial College London. Well, we know that surveillance, or should I say monitoring, is expensive, and it might blow the budget, the very constrained budget for some of the poorest countries in the world. And we heard this morning from the health minister that evidence on cost effectiveness of pandemic preparedness interventions is lacking. What do you see are the priorities for conducting solid cost effectiveness analyses for monitoring surveillance? Thank you.
Okay, I'm happy to answer that. No, I couldn't agree more. So I think, and what are the priorities? I think, so first of all, the funding is not there, and the pandemic fund is part of, that's part of the reason for the pandemic fund. That's why it's so important that the pandemic fund becomes a success in those projects. And I think the second is yes, we are lacking evidence, and I think we're lacking solid evidence about this prevention paradox, right? And I think about the sort of value of having a solid public health system, which I would say is the basis of, or which include the sort of basic surveillance systems, as well as then the ability to respond to outbreaks and calculate sort of escalation of cases prevented. And I think it's almost, I mean, you're at Imperial College, it's a research agenda, it's a dream, right? You could, I think there really is almost any aspect of that which you would want to take. I don't know, maybe Jeremy would say, oh, go by pathogen, other people would go by risk factor. So I think, but that's the beauty of science in a way, to open that up. And I think, again, part of the work that we're trying to do with that, I don't want to put it all on Chikwe's shoulders, but the work that of Jeremy and Chikwe is to define a research agenda around that. We are partners in that, and I think so are you and everyone else in the room. But I think we would value also your input into how to phrase those questions.
Thank you. I would take one more question from the audience. Yes, please. Here in the middle of it. Thank you.
My name is Janti Luklimisch. I work with CBM, but also speak on behalf of the German umbrella network, Venro on global health. I would like to add on that debate on surveillance and monitoring, and would like to ask, for building trust, how important could the inclusion of affected groups, of civil society participation could be? We didn't hear so much yet today about civil society participation. So for disaggregated data, for including those affected or those vulnerable groups as people with disabilities, do you have any examples that when you include them in the monitoring, that helps also for building trust then on surveillance issues? Thank you.
Who would like to address that question?
I can start very quickly, and then I think my colleagues can comment from their experience as well. You know, I had this conversation with Caroline from the Pandemic Action Network just this morning, actually. This is a whole blind area for us. You know, we've often seen the responsibility for surveillance as only the responsibility of one national institute responsible for doing it. But we're now kind of defining a lot more broadly, both with academia, with all sorts of parts of society, and the ones you mentioned are definitely most important. And now especially, COVID has highlighted the differential impact of a virus on different parts of the population. I think it highlights the need even more. So thanks for raising the point. Of course, I don't have a clear answer for you. I think Marion wants to come in, she give us some insights, but very important point you've made on especially on the differential impact of pandemic causing pathogens, specifically for this conversation, but for all health issues actually.
Ms. Kopman?
Yes, I think the issue of bringing things to community is also about considering how to work with citizen scientists. There are very interesting examples in, for instance, the bird monitoring field, in the mosquito monitoring field. And these are loosely organized groups that just share information out of interest and are happy to also contribute to whatever systems are being developed. And that is a very new way, not really a new way, but it is certainly for the organized public health surveillance. It is a way of working that really needs to be explored to see how you can reliably work with citizen science data. But I do, from my experience, see quite interesting buy-in by, for instance, involving schools and school programs into things like mosquito monitoring surveillance programs. So that is a dimension that I think really has a lot of promise.
Thank you so much. I have one more question for all panelists here, because we have been talking a lot about communication as well. And a question that comes up, because I did some reports during the pandemic, what people would ask would be, why do you need my data? How would it help? So let me ask you, what if we would have been perfectly prepared before the COVID pandemic regarding surveillance and data sharing? What would have been different? Would we have avoided the pandemic? Or please, a short answer though.
So, two short answers.
Okay, two is okay.
One is, I don't think there's perfect preparedness.
Okay.
And I think the second thing, it still relies on response. So even if we'd had perfect data, we would have still, we need to strengthen the health workforce alongside. So that's where the two go together.
Mm-hmm.
So, one short answer. When we think about surveillance, we always think about what we would do, right, with the data we collect. Yeah. What if we think about what we wouldn't have done during the pandemic? So when I was advising the Nigerian government in the beginning of the pandemic, our surveillance was very poor, and then we had to use blunt instruments like lockdowns for the entire country. If I had more precise data, we wouldn't have locked down the entire country. It would have been much more precise in where we would have taken action, and maybe we wouldn't have incurred the wrath of the 80% of the country that felt they were locked down without sufficient reason or cost to do so. So I know the answer is a little bit more nuanced than that, but I do think there's a likelihood of leaders having a lot more support from the citizens for the actions they take if they could explain it a lot more with a lot more precision in terms of the impact of whatever the issue they're dealing with.
Thank you.
Yes, if we had good preparedness and including good surveillance, and then we have adequate human resource, what it would mean is that public health events that will be picked up early, and the response would also be early. And we know that when we respond to these events early, we are able to mitigate the health and the socioeconomic consequences of these events. So good preparedness would allow for early detection, early institution of response, and mitigation of the consequences of these events.
So yeah, I don't know if there is perfect surveillance or preparedness, I don't know, but in my ideal world, like that will be the world where everyone will perfectly collaborate with each other. So this means, so we will have, so we need data, we really need data, but it's also responsibility of communicating to the citizens which kind of data is being collected, why is this information important, why this data needs to be collected, and also from the technological point of view, it is also responsibility to follow some guidelines. Like in the case of SORMAS, obviously this is what I can speak for, like we follow GDPR regulations, and this is important that citizens know that data is collected, but it's following some guidelines and some regulations, not just like this. So, yeah.
that they know that there are rules and their information and their data.
And it's not just collected just because. It's collected for a purpose and following some procedures.
Ms. Koopmans, please.
Yes, the perfect world. I think two things would have potentially made a difference. I think from the get-go, we would have taken into account evolution of the virus and evolution of viral traits. So that's one aspect. So things downstream maybe would have been slightly more foreseeable, the rapid evolution of variants and what that did to the pandemic. And the other thing, perfect scenario, I think we would not have newly established animal reservoir, for instance, like in the deer in the US, or the situations that we've seen and continue to see in mink. Because that, so the early pandemic response was not a One Health response, and I think that was a bit of an oversight. So that would be on my future golden system list.
Thank you so much, Ms. Koopmans, Ms. Hernandez, Mr. Antara, Ms. Hannefeld, and Ms. Ikawatsu. Thank you so much for this panel. Please take a seat in the first row. Okay, before we go to the next break, I would like to introduce you to our 3 moderators for the next 3 workshops that will start at 4:40 p.m. So please let me ask Mr. Douglas Noble, thank you, Mr. Fabian Lindertz, and Ms. Helen Hamilton on stage. They will present briefly their workshops, and the workshops will take place, one of them with Mr. Noble here in the main room, with Mr. Lindertz in the film room. That one is on the left side, back there. And the DigiLab is for Ms. Hamilton. So please, the floor is yours to present your workshops briefly, please.
Shall I start? Okay, great. Well, hope you've had a very interesting day with the plenaries and some fantastic inputs that we've had across the day. At the workshop I'm going to be doing, it'll be your opportunity to do all the talking and to come and share your views. And we're going to be looking at something quite interesting, I think, which is the intersection between health systems and health system strengthening and pandemic preparedness and response. And there's a sweet spot in the middle there, because we have to strengthen health systems to improve pandemic preparedness. But of course, health systems are bigger than pandemic preparedness, and pandemic preparedness is bigger than health systems. So we're really going to be looking in that middle zone together. We'll have 6 groups in here today on leadership and governance, high quality and safe delivery, health system financing, health workforce, digitalized health information, and medical supplies and commodities. And then we're going to be pushing you from your workplaces, well, not the global debate, but from your workplaces, to talk about strengths and weaknesses, improvements that need to be made as regards health emergencies, preparedness and response. And 3 of us, myself, my colleague Jerome from UNICEF, Carolyn from Pandemic Action Network, we're going to circulate around, we'll give you some hints and some tips, and hopefully we get a really good discussion going in these groups, and we'll report back. And then share findings together and have a sort of summary outcome from the meeting across those domains, and particularly looking at how we strengthen those areas for pandemic preparedness and response, and think more broadly as well about all the different sectors. So that's what's going to be here in this room.
Yes, so I will chair the second session on human-animal interface spillover prevention. So when I got the invitation to chair the session, I said, well, that's a difficult task and a difficult topic, because if we look at the definition by OLAP of prevention, that's what I would like to use. So it's really preventing the spillover. Yeah, so really before the jump happens. And what can we do there in the different fields, in the different disciplines, in the different settings? And it's quite complex, and you cannot generalize things. But still, I think it's worth a discussion. We have a great people in the room. We will also have a very open format and invite people into the inner circle. And I hope to get a One Health perspective on prevention. I hope there will be people also from the field of environment in the room, which is perhaps not so well presented here, but let's hope. We will have the animal side and the human side, and then we will also have a short summary, if I understood right, to be presented to the audience, or at least distributed to the audience later. Thanks a lot.
Is that working? Yeah. Great. So our session will focus on water sanitation and hygiene for infection prevention. And we know that safely managed water sanitation, hygiene, and behaviour change services are crucial for preventing infectious disease outbreaks and addressing health challenges through a One Health approach. And on that basis, we know that poor wash conditions underlie many health issues contributing to disease transmission, including which will worsen climate change. So we know that good wash is essential to serve as a barrier for human-to-human transition in the infectious disease aspects across homes, healthcare facilities, as well as schools and other public institutions. But we know that there's real urgency to addressing this critical component when we consider some of the staggering statistics. So we know that 1 in 10 people globally don't have water close to home, and almost 3.4 billion people can't rely on safe sanitation. And one of the ones that always, I don't know, gives me a shudder is 43% of human fecal waste ends up in the environment completely untreated. You know, so when we're looking at things that we need to do to prevent against the spread of infectious diseases, these are some of the absolute fundamentals. Similarly, our healthcare facilities, and we were talking about this with Mike Ryan at lunch, you know, when we say 2/3 lack basic hygiene and half lack a basic water service, these are really extreme figures, and they only get worse in least developed countries. So we know that this is a foundational pillar. When we assume we have universal health coverage or primary health care, some of these assumptions are based on really uncertain ground, right? If we're assuming we have water, sanitation, hygiene in healthcare facilities and homes to prevent us. So we know that addressing this silent crisis is a solvable part of a larger challenge, not a utopian dream. And it will only cost us under $10 billion by the end of the decade to ensure clean water, sanitation, hygiene in the least developed countries. So in terms of public health, this is an incredibly affordable investment. So our session today, in collaboration with the German WASH Network partners, is dedicated to strengthening healthcare systems through WASH. And the WASH Network has been kind enough to nominate myself and Ludmila Lokovitz from Malteser International to co-facilitate a session on WASH for infection prevention control. So we invite you to come and join the session. We'll be delving into opportunities, and we'll be very action-orientated and be calling on you to think about the technical, the financing, and the political leadership needed to strengthen WASH for prevention and infection prevention control, but also to ensure that WASH more broadly is prioritised in One Health and in pandemic preparedness. So we want to hear your ideas. We want to make sure that this is a really collaborative effort, and we'll be really pushing you, like others have said, to think about not what can others do, but what do we need to see in general, but also what can stakeholders here also take away from this conference.
Thank you. And as Mr. Lendertz already mentioned, we will have different boards, 3 boards for each workshop, and we'll take a look at the results. And obviously the results are going to be forwarded to the ministry, so this will also have an impact, hopefully on the policies and the policy making of the German ministries that are hosting this event today. Thank you so much. We have a break now until 4:40, and then you will find your workshop and your room accordingly. You can also see the number of the workshop you're in on your badge, so that shouldn't be a problem. Thank you so much. Thanks, that was great.